Tough topic. This area, just like the one I talked about yesterday, it's exploding. There is so much information, and I'm going to try and make this pretty simple. So apologies if it looks too simple for some people, and then try and make it practical by giving an example of a disease that we all know about, just to see how this information can apply to us in our day-to-day lives. So no conflicts to declare. And do people have their clickers? If not, let's just do a show of hands. So how many of you think that genomics will change your practice? If you think it's not going to change your practice in your lifetime, raise your hands. Okay. And I see this is coming from people practicing in India. I think the clickers are not there, so we'll just do this. Do you think it'll change a little bit? Raise your hands. Okay. And do you think it's going to have a big impact? Raise your hands. All right, so we're pretty split audience, and we'll see if this talk makes a difference in that poll. So little bit of basic science to start off the morning, unfortunately, but hopefully this will actually wake some people up. So we start off with the DNA. That becomes the RNA. And this little yellow squiggly thing at the bottom, orange thing, is the RNA that is created from the template of the DNA. That process is called transcription. That RNA goes into the cytoplasm. The first two steps happen in the nucleus. This goes into the cytoplasm. And this is the code that builds proteins in the ribosomes. And that is the fundamental point that I don't want you to forget. The DNA does not code for fats. It does not code for carbohydrate. It codes for amino acids. And you remember the DNA is made up of the A, T, G, C. Three of those together. So you can say GAG. That codes for one amino acid, and it's called a codon. So every three little bits code for one amino acid. We have a few billion of these codons in our DNA in one person. So you can imagine the complexity of how many different types of proteins can be created. And proteins include things like enzymes. They include things like the globulins. So all of that leads to everything else that happens in the body. All right? So remember, there is the codon, which codes for amino acid, and the entire DNA, out of that, only about 2% is our genes. That is what codes for everything else that happens in the body. And what we still don't know is what the rest of the DNA does. Okay? Now, this will start giving you an idea of how complex this is. So this is one chromosome. It's one long linear molecule, all bound together, like you can see, it's wound together. And it is bound using what some of you will remember are histones. Now, why is this important? So when it is packaged like this, the part of the DNA, you can see is part of it is wound like a spool on a film reel. That is not available to transcribe into RNA. It's all bound up. So the only part that is free is what can be transcribed easily. Now, that's not 100% true, but I think it's easy to remember it that way. So most of the DNA is wound up, and that's why it's not available to become RNA. And so remember that we have DNA, which becomes RNA, which becomes proteins, and most of the DNA is bound up in a way that it cannot code for anything. But if you actually straighten out that whole DNA molecule, I just want to highlight a couple things here because this will help you understand most of the genomic basis of disease. So if you look at this, that is actually the gene. Okay? The part before and the part after are not genes and they're not transcribed. So that is the 98% of the DNA. And then even within the gene, there are introns which are not transcribed. Those are removed, and it leaves you with what is called this you should know, it's called the open reading frame, ORF, and that is really what codes for amino acid. So you can see all this DNA is slowly being whittled down till you actually get what becomes the RNA. all right? So what is the point of all this other DNA? And this is just a magnified view of the start. This is the part just before this red rectangle. And you can see we have promoters, we have silencers, we have enhancers. So the part that is before and after the DNA, the gene, actually codes for whether that DNA is active or not. So not only is the fact that some DNA is wound up tightly, it's also that there are parts around the DNA of the gene that chemicals can act on to activate that gene or suppress that gene. Most cancers are related to genes that are activated or inactivated. They're turned on or off. So you may have a gene that could cause cancer and never get cancer. Okay? So hopefully you remember this as we go into the details of one disease. And I mentioned this briefly yesterday. Epigenetics is basically related to the fact that our behavior and our environment. So if you smoke, it changes one of the promoters or silencers, and that turns on the gene that gives you lung cancer. Okay? So this is how things we do impact our DNA. It doesn't really change the DNA, it turns it on or off. So keep that in mind. So the DNA sequence itself does not change. And the way this changes is either gets bound tightly or it gets something that you may or may not know is methylated. So that is the limit of basic science that we're going to talk about today. All right? So to make sense of this, I thought of one disease that really all of us know about, and that is hemoglobin diseases. So it's the most common single gene disease in humans. And what we know is the hemoglobin is composed of 4 subunits. Each subunit has a protein chain with a heme molecule stuck in there, inside which is iron. Now remember, humans have 2 alpha and 2 beta globin chains. And any change here is what causes the hemoglobinopathies. Alpha is chromosome 16 and beta is coded in chromosome 11. So this is what it looks like. There are 8 segments of the globin chain, and that purple thing in between is the heme molecule. And it's attached to the globin chain with 2 amino acids. So what happens in sickle cell? Remember the codon? One change in codon in the 6th amino acid in the chain of the beta globin, and this is caused by a change from A to T. So instead of GAG, it is GTG. That causes all the disease in people who have sickle cell disease. On the opposite side is thalassemia, and what happens here is, remember the part outside the gene, it's the promoter. It's the change in the promoter region that decides that now some of the beta globin chains may not be made, and less are made, so you may have more alpha, right? There is a whole bunch of these hemoglobinopathies, but I'm just trying to give you an idea. One is a change in the promoter region, one is a change in the actual codon in the gene that gets coded. So keep that in mind. So what implication does this have for us, right? So we know that we get this change from beta. So here from GAG it becomes GTG. And then what that does is it makes the hemoglobin into what we call hemoglobin S. And when there is oxygen, it is great. But when it gets deoxygenated, it polymerizes. And it becomes stiff, makes the RBC stiff and bent, and so it cannot navigate through small blood vessels and people get the crisis, right? So why is this important? Well, what has happened is now we can actually fix this. So more and more we are going to be able to look at disease groups and say, where is the problem? Because like we said yesterday, we can sequence entire human genomes in a day. And we can compare them with normal people. We find where the problem is, and now we have tools that we can actually change these. So here is a human. You take their blood, they have sickle cell, so this is autologous. You don't need to worry about graft rejection and stem cell rejection. And then you collect their blood, you take a virus that has the right DNA code, you put that virus into that blood, it changes the person's code. So instead of GTG, it goes back to GAG, and now you inject it back into them. And does this work, right? So now you take these stem cells, you put them back into the human. Does it work? It does. This is a NEJM paper. Everyone recognizes the logo. And this paper actually showed that with a virus, you can change and cure a person's sickle cell disease. And did it work? Well, just a couple images. So clearly, LDH goes up in people with hemolysis. Here it dropped. The retic count went down and stayed low. And their indirect bilirubin level, the non-conjugated one, stayed low. So clearly, clinically, it worked. What matters the most? All the red dots are people who had a sickle cell crisis. Every crisis is a red dot. The gray bar is when they got the injected, corrected blood. Almost no crisis in any patient after that. This really works. So that is one way of fixing the DNA. The other, you will never be asked what CRISPR stands for. So forget the clustered, regular, interspersed, short palindromic sequences. People never remember that. But what you need to know is here is a bit of RNA, the purple line. The blue is the enzyme. And what it does is the RNA is a one-to-one relationship with segments of DNA. So the RNA will take the enzyme to the part of the DNA you want to fix. The enzyme comes from bacteria that figured out a way to protect themselves from viruses. And you can, with a surgical precision, change that person's DNA using this enzyme and RNA bound together. So this is what CRISPR is. And it has been used and in fixing a lot of things. Milind is here. He probably may recognize there is a mutation called MYBPC3. This causes about 30% of cardiomyopathies. And in China, they were able to go in and fix this, and it's called a germline editing because it fixes it so the fix passes on through generations. So you can imagine now, you can go into utero in someone who has a problem. They've done this in people to change their genes so they become less susceptible to HIV. Very controversial because now you can create a race of people that's different than others. So this is banned in most countries. But you can change somatic mutations like sickle cell in the people in whom you fix. It's not inherited. But germline genomic editing is very controversial, but you will probably hear more about it. A lot of applications to CRISPR, a lot of diseases, and it'll keep growing. The other thing you need to know about is something called SNP. These are tested, 23andMe, all these studies, and basically it's one change in mutation, one mutation, all right? And it's common enough to be called a SNP. So it has to be present in 1% of the population. People have millions of these. Everyone has millions of these, all right? Some of them have impact. Like I said, it's ApoE, most of you know. It's related to Alzheimer's, right? So these, knowing all the SNPs that are there and how they cause disease is going to be important. And one area with this, I think, may be interesting to some of the younger people who want to do research is GWAS studies. So what GWAS is in Caucasian populations, we know that a particular area of one chromosome causes many Parkinson's diseases that are run in families. That's not the same set of SNPs in every ethnic group. So there are studies going on as to how do these SNPs compare in different ethnic groups. So it's wide open in India. If you have access to people doing genomic research, want to do GWAS, pick up a disease that runs in certain parts of the chromosome and compare to what is known in the Caucasian, and you have a fantastic research project knowing how it's going to impact Indian population. So I'm going to skip this because thinking more about it, this gets pretty detailed, more than what we want to know. But essentially, cases will have some genomes, and the control will not have those problems. And a lot of applications, again, for GWAS studies. So take-home points, remember codons, remember that genetics is related to the genes, but 98% of the genome is not DNA and is not represented, and that is genomics. And SNPs and inheritance, epigenetics, and transferring and fixing genes with vectors and CRISPR and GWAS. So I wanted to leave you with just a whole cookbook of vocabulary and terms, but this is a very rapidly growing area, and if you are interested, dive in. This is huge. Thank you.
Bioresorbable absorbable scaffold stents, an update. It is obsolete or a way forward to future coronary intervention?
Nothing to disclose. Don't get any sponsorship from any of the bioabsorbable or any other stent companies. And as you see, development of coronary stents have taken place over a last 20, 25 years, almost 30 years history. And the slide I showed many years ago was this one about drug-eluting stents, which are very much here after almost 20 years since Cypher came. Cypher stent of Johnson & Johnson discontinued, but many others, second, third, and fourth generation came. And then a few years ago, I talked to you about bioabsorbable scaffolds, as it is called, rather than stents. And it came with a big bang, and in 2017, exactly 5 years ago, there was a storm where bioabsorbable stents were shown to cause late thrombosis, subacute thrombosis, and even early thrombosis. And Abbott, under the advice of some prominent cardiologist, withdrew the scaffold or stent. Interestingly, the mortality difference was never shown. So we had again angioplasty, stents, bare metal drug, absorbable stent, and then it was withdrawn. So the whole area became very muddy, very doubtful, but still we have an issue. When we put metallic stents, the metals stay here. And over a period of time, there is endothelialization and people have done very well. But when you put multiple stents, you have all this metal lying in the arteries. On the other hand, with successful bioabsorbable scaffolds, the artery became almost like normal after a few years. So the entire concept was that if you put bioabsorbable scaffold, nothing is left behind. Your artery goes back to the original nature. So what happened with absorb? With absorb, what happened was the struts were thicker, there was under expansion, and this led to early thrombosis. Under expansion was because partly inexperience of the operators, partly inability of the company to teach the operators, and partly the thicker struts and the way it was made did not allow proper expansion. And this led to later on late thrombosis also. And as you see, that late thrombosis took place and people went back and saw some of these cases. So as you see, again, after angioplasty, there was angiographic, it looked good, but in OCT, there was not proper apposition, and all that led to the disaster. However, the science behind bioabsorbable stent was terrific. So people, multiple companies out of India, China, Europe, and USA continued, and Merrill Science, whose booth is outside, continued with their research, and they came with a much, almost 40 to 50% thinner bioabsorbable scaffold of various length and diameter. They call it Maris 100. And early clinical data out of their clinical studies showed very good results at 3 years. So first I'll show you some of my cases where I used Absorb, and this is a patient with a very diffuse LAD, as you see, very diffuse. And these are cases which are not good for surgery also, because there is not much target. The case I'm going to show, these are diffuse LAD lesions. And in these diffuse LAD lesions or different arterial lesions, the bioabsorbable, which we put almost 7 years, 8 years ago. So this is an artery which we did multiple bioabsorbable stent. So this is a gentleman, I put 4 absorb back in 2013 or 14, and with his permission, he is Mr. Kapasi of the Kapasi Emporium. He lives in Africa. He's still doing extremely well, and I did his follow-up angiography as well as CT angio. All the absorbable stents have been absorbed, the artery is wide open. So here, this is a young 33-year-old male with a critical LAD disease on the top and circumflex lesion. Now I'll come to Maris. Maris has now released about a year ago their absorbable scaffold approved by DCGI, available in India very freely. And this is a young 33-year-old male. So as I show the slides, this is the indication. Young people, diffuse disease, multiple stents required. You do not want to put multiple stents in these patients because it may create a lot of issues in future. So you see this LAD is the final result. And if you see here, the artery is well opened, and we put, I believe here, 3 stents, 3 Maris scaffolds, they like to call it scaffolds. I think you can still call it stents. And there was no, and this was almost November 22, a few months ago. So to conclude, bioabsorbable scaffolds are very much here to stay. It will change the landscape because it brings the artery back to its normal form. The complications of late thrombosis, late deaths, which were seen in the first generation. You have to understand the Abbott Absorb was the first generation. Maris stent is actually 3rd generation. Then they are 4th and 5th. So the newer BVS leads to complete biodegradation of the device, restoration of normal vasomotion, restoration of normal shear stress and cyclic strain. The artery becomes as good as normal. And in those early studies of these new generation stents of Maris as well as other couple of companies are not showing the late thrombosis. And Dr. Antonio Colombo, who is world leader in angioplasty stents, one of the first pioneers, has gone back to using these bioabsorbable scaffolds again in significant patients where multiple stents are required, and low rate of cardiac events are now coming up at 5 years in these newer stents. So with this, I will conclude by just emphasizing that bioabsorbable stents or bioabsorbable scaffolds are here to stay. Over the next 5 years, they will come back in a bigger way. And if your younger patients have multi-lesions, long lesions, and when you refer to the cardiologist, mention to him to consider bioabsorbable scaffolds. Thank you very much.
Today's topic is going to be telemedicine, and no financial disclosure with regards to this talk. The rapid adaptation of telemedicine in a few short years with widespread use of digital tools changed the healthcare landscape, making care easier and more accessible to millions of patients. And studies show that 66% Americans are willing to meet their doctors. I don't have the data in India, but I think majority of Americans are adapting to this. And after the COVID pandemic, there has been a rise in telemedicine and driven by safety concerns during pandemic. More than 50% of patients had some form of virtual visit in 2020. And with the relax of federal regulations in US, Medicare saw 53 million virtual visits in 2020 compared to less than 1 million in 2019. And increased acceptance by patients by using this new technology can mean greater productivity and profitability for your practice. And oversee treatment plans by easier check-ins and for both provider and the patient, and help manage medications and reduce demand on staff for refills by e-prescriptions, review lab and test results easily, relay sensitive information face-to-face from home, and post-procedure care quality can be improved by removing the obstacles. Over the past couple of years, telemedicine has been a critical tool in ensuring continuous care for millions of patients. Even an in-office appointment have become possible again. Telehealth visits continue to grow in popularity, both among patients and healthcare providers and health systems. The tide of telemedicine helped, however, in 2022, we saw only to 11% increase in virtual visits because, as we saw, more and more patients came back to the office visits. So we have this dual channel system now, where in-person and virtual care, which I personally use a lot in my patient visits, are becoming more standard of care. Like you see a patient first time in person, and you can switch the patient to telehealth and vice versa. However, the rapid change and adaptation of technology continue to be stressful on many healthcare practitioners. There's something called video fatigue, overwork and burnout could be an issue, and we need to balance both the in-person and televisits. So again, to summarize some of the potential benefits: expand access of telemedicine, focus on safety, improve adherence and engagement with patient and physician, and reduce costs, address challenges related to mobility and transportation for especially elderly people and disabled, and decrease stress about any stigma they have, and match or increase effectiveness, facilitate group visits. You can have multiple patients as long as they permit, and you can have family also be part of the visits. And limitations include technological requirements. A lot of patients are not comfortable with new technologies, and providers need to be trained, and less reliable on vital signs because you have to rely on patient and the family member to give you vital signs, and inability to perform physical exam. In some patients, we may need to examine a patient. Limited training for injectables, even though these days we can have YouTube to have them understand how to inject medications. Accessible to lab draw testing, need for privacy software, especially in US we have the HIPAA compliance is required, and security concerns. So ways to streamline, improve telemedicine practices. Number one, to serve patients well means serving them in the way that best fits their lifestyle. To ensure a better experience for you and your patients, prep your patients in advance, get the virtual setup and reduce wait times, and consider accessible functions, convey empathy in your virtual healthcare setting, always follow up. And number one, prep your patients in advance. Virtual health visits are still new. The patients may feel anxious or uneasy, and especially older patients. The more you prepare your patients for their visit, the smoother the appointment will be. And patients may not be understandable when something needs to be evaluated in person, and may seek more virtual care when appointment in the facility is actually more appropriate. Minimize remote appointments with improved efficiency. And consent forms and questionnaires can be a great way in understanding telemedicine ahead of the visit. And written instructions on how to use the platform and what is expected of them will help them make me more comfortable. Number two, get the right virtual setup. Most underestimated aspect of virtual care is the right video conference setup. A well-lit office and a professional attire will help the patient to be at ease. Right audio equipment will ensure no communication problems, and creating a proper setup will ensure better communication. Select a solid color background such as a plain wall or a solid color fabric. Reduce unnecessary noise such as a fan or outside traffic. Keep lights in front of you instead of behind you. An inexpensive ring light may help create a more professional environment. Number three, consider accessibility functions. When creating a process and visual setups, ensure proper arrangements for those with disabilities and those who are unable to use technology efficiently. For example, you can have a certified language interpreters. It's widely available in US, and I'm sure in India it's available, both for video and audio visits. And patients for deaf and hearing impaired patients may require alternative means of communication like sign language interpreter. And again, a telemedicine platform is very different atmosphere from in-person appointment, but conveying empathy is still very critical for patient care. It takes different verbal and non-verbal cues to show patients that you are engaged in a conversation, and empathy. For example, some of the tips are: ask questions to establish a provider-patient relationship, such as, is this your first telehealth appointment? Acknowledging what patients tell you, like, I'm sorry that you don't feel well and that sounds painful. Address emotional cues such as a sad face or an angry posture with questions showing your concern. So use nonverbal communication cues such as leaning towards the camera and nodding your head, like simple things like that to make them people engaged with you. And patients need to be, they need to feel supported and heard, and that is conveyed over video differs from in-person. and make a conscious effort to display empathy in ways that their patients can connect with the virtual health space. Again, number 5, always follow up. Care continuity can be an issue in telemedicine. Providers must follow with patients to ensure they understand what was discussed and that they don't have any additional questions. And sometimes I've used a chat box and we do type patients and I give instructions, and that helps patients engage, understand what was told. And automated emails sometimes can help, text notification for follow-up visits, which doesn't require much of physician time. You know, your office staff can do that. However, they will also go a long way in providing an extra personal touch after their appointment so that, you know, your office is following up these people. So always look for a video visit upgrade platform. In IT, people keeps working on doing this. Work closely with them, understand and how resolve your performance issue and express your concerns. And an update should be seamless and with an existing EMR or a desktop or an iPad. And key improvements should include quality, improved quality with a low bandwidth. Sometimes the video quality could be poor because of the bandwidth. Dynamic adaptations to network changes. And participant can test the camera, microphone, speaker before and during the video visit. Always be open to receive feedbacks, to impact changes. And I have an internal IT support, always helpful to help the patients and the providers. And I have a toll-free number where the patients can easily call, because the biggest problem is patients always ask, oh, my video is not working, I cannot sign up, and you don't know whom to call, and that should be avoided. And Zoom for healthcare. In Mount Sinai Health System, we use Zoom as a primary platform now, and I'm sure every healthcare system uses different platforms. And there's reference guides available, and there should be an institutional app where you can easily go in and sign up, and links to the Zoom. And web browser can be a little bit slower. We need to make sure your mobile devices can easily work faster. And there should be a virtual waiting room to make sure the patients are understandable. And these days we use an alternative platform called Doximity. Doximity is very useful, which is where patients cannot log into Zoom, and we use our smartphone to log into your patients, send them a text message, they log in, very easy to communicate patients. So creating a better virtual care experience can help reduce clinician burnout too. As more providers offer telemedicine appointments for patients, creating a more efficient workflow is important for a good patient experience and avoid frustration among physicians. Even as few simple changes will ensure a smoother process for everyone. Virtual visit can be the first step in patient's care journey, and can be extended in person. That's why a lot of times I do a virtual visit, then followed by in-person visit. And patients, the forms of virtual care don't even have to be high-tech. We learned during the pandemic that, example, a phone call or a simple text message to a patient will improve physician-patient interaction, and that makes the visit more comfortable. So the goal is to marry digital and in-person services in a way other sectors have adapted. As you know, people have become more accustomed to digital technologies. Even, for example, banking and other industries are going into more digital technology. Healthcare can move in the same direction. Hopefully we can get into more deeper understanding and relationship with our patients. And consumers have more and more choices these days, and because they're more savvy with their feet and fingertips. And the innovation of digital health is important. More than 400,000 healthcare smartphone applications are available, and promising track visits, monitor exercise, and manage chronic conditions. That's called a doc in a box. Telemedicine companies are available, and they are working very hard to improve this. Single consumer protocol to provide integrated way to perform tasks such as ordering medications, communications with care team across sites of care, interoperable electronic health record, allow patients and providers to see entire health record in one place. And flexibility and communicating by standby virtual care channels like phone calls, texts, and emails improve ability to engage with patients and achieve great outcomes. And create channels that are convenient for patients to connect with their provider, lowering their barrier to care and patient engagement. So basically, a greater engagement remains healthier people. And I think telemedicine does help. So this is one of the slide summarizing the CVS is a big pharmacy chain in the US, summarizing how virtual care was viewed by both physicians and patients. 40% of consumers had healthcare visits in the past year. They found virtual healthcare is here to stay. And compared to in-person visits, consumers think virtual health visits were 33% better. And consumers also said they like virtual care because it's convenient, it's faster, it is safer. However, they come with limitations that services are limited, they don't have much it costs, and technology is still confusing. And comfort with health technology varies, especially among older Americans. A lot of old Americans are not getting used to it, but we are trying to encourage that to change. And people over 50 say that barriers to healthcare include cost, lack of knowledge, and privacy concerns, and lack of interest, and so on and so forth. So some of the unanswered questions are, will regulations and insurance company continue to facilitate remote care? It's still the question. Can providers deliver rapport, deliver education, and provide support necessarily to partner with patients against their disease? And so take-home message, in our communities, telemedicine care is a big step forward and a tremendous opportunity, but the benefits aren't universally enjoyed it. It ensures responsible, safe, effective, comprehensive, personalized, accessible, affordable, long-term cardiovascular treatment. Virtual care eases the patient's vulnerability, that is stigma for not being cared for when they're seen in person, because they're receiving care in a safe place in their home. In the near term, it will call for education, patience, and a lot of flexibility as we bring everyone on board. You need to identify and encourage patient who is a good fit for telemedicine. That's what I always say when I see a patient in my practice. Identify who is good for telemedicine. I ask them, are you willing to do telemedicine? So you can follow these patients and document that. And big takeaway is that access to healthcare should be flexible and offered everywhere to patients needed. And many people want a combination of modalities, and we don't make an assumption that everyone's journey is the same. For most consumers, jumping into waters of virtual care has been rewarding. There's a survey in Stanford University found that patients at a video call were satisfying more than the in-person visit. With more experience in digital health through virtual visits, smartphone apps, and online health records, consumers are becoming clearer about the kind of experience that work for them. Thank you for your attention.
So like every year, I'll try to cover whatever I can in given time. So I'll try to discuss there are so many good trials, but I have selected something which can be useful in our day-to-day clinical practice. So I'll cover first half today. We'll see whatever I can today. So every time there is some question at the end of the trial, after 3, 4, 5 slides, we'll see whether it has changed our practice or not. So do you have voting pad? Then give answer to this. Dapagliflozin. It reduces 3-point MACE, that is death, MI, and stroke, has anti-atherosclerotic effect. It is CV benefit is more among diabetics than non-diabetics. It is useful for heart failure patient with EF more than 50 or all of the above. Time starts now. So we'll go through. So DELIVER is the trial, which shows a trial of dapagliflozin in heart failure with mildly reduced or preserved ejection fraction. It was a multi-center RCT of nearly 6,200 patients with class 2 to 4 heart failure, whose EF was more than 40. Remember that DAPA-HF was less than 40, here it is more than 40. So there is DELIVER trial with the dapagliflozin, and had raised anti-BroANP and evidence of structural heart disease. So patients were also included during admissions for acute decompensated heart failure after they become stable, and 55% patients were non-diabetic, and follow-up was 2.3 years. Mean EF of these patients were 54%, and majority were on guideline-directed medical therapy. Primary endpoint of composite of CV death and worsening heart failure was reduced by 18% with DAPA, and that was highly significant. The main benefit was driven by 21% risk reduction in worsening heart failure, and there was no significant reduction in CV death with dapagliflozin. Beneficial effects of dapagliflozin was seen at all levels of EF, whether EF was 40 to 50, 50 to 60, or more than 60%. And the same was seen with dapagliflozin was given during index admissions for acute decompensated heart failure. Once they were stabilized in 3 to 5 days, before even they were discharged, they were put on dapagliflozin, and patients got benefit. So message was very clear. Like empagliflozin in Emperor Preserve trial, DAPA also reduced combined risk of worsening heart failure or CV death among patients with EF more than 40% and beyond. So correct answer For our, this thing is fourth. This 10% only. See, DAPA was shown, DAPA trial was there, declared TIMI trial, which was the first trial of dapagliflozin. I'm not talking about heart failure in general, and 3-point MACE was studied. Only empagliflozin and canagliflozin reduced 3-point MACE. DAPA did not reduce. So death, MI, and stroke was not reduced by DAPA. DAPA is not anti-atherosclerotic. Its main benefit is for heart failure and kidney, renal benefit. So it is not anti-atherosclerotic. Its CV benefit is more among diabetics and non-diabetics? No, both are equal. It is useful for heart failure with preserved ejection fraction. That is what this DELIVER trial proved. So correct answer is fourth. So we have learned something. Next question. See, meta-analysis of SGLT2 inhibitors show that they reduce the risk of stroke, reduce risk of MI, reduce risk of death, are effective even if GFR is less than 15 or all of the above. So your time starts now. So let us see. So this is a meta-analysis. It was a comprehensive meta-analysis of 5 RCTs of SGLT2 inhibitors in heart failure, and this was published in Lancet. None of the individual trial actually could demonstrate CV mortality benefit due to low power of the study. So pooled data of 5 trials with nearly 22,000 patients gave enough power to assess effect of SGLT2 inhibitors on CV mortality. These 5 trials included trials of DAPA, EMPA, and sotagliflozin for entire spectrum of heart failure, regardless of level of ejection fraction. All trials had nearly similar design and inclusion criteria, and primary endpoint was time to first cardiovascular death and heart failure hospitalization. And on pooled data, primary endpoint of CV death and heart failure hospitalization was reduced by 23%, and that was highly significant. Similarly, heart failure admissions was reduced by 28%. And pooled data could demonstrate 13% in reduction in CV mortality also. So it was for the first time that we could see that there is a cardiovascular mortality benefit when power of these trials was pulled together, and this was also statistically significant. And not only CV mortality, even all-cause death was reduced by 8%, and that was also significant. So message from this trial was, this meta-analysis was that pooled data of more than 21,000 patients, it clearly showed that SGLT2 inhibitors not only reduces CV death and heart failure admissions, but also reduce CV death itself. It reduced all-cause death in a broad range of patients with heart failure, irrespective of ejection fraction or presence or absence of diabetes. So correct answer for this is again reduction in risk of death. So again, still we are in minority. We learn something again. It doesn't reduce risk of stroke. It doesn't reduce risk of MI. And if you are thinking about eGFR, EMPA was studied up to GFR of 20, DAPA was studied up to GFR of 25, and SOTA was studied up to GFR of 30. So beyond that, there is no proof. So it is not useful if GFR is less than 15. Third trial, question. In acute decompensated heart failure, all of the following are useful except torsemide, dobutamine, acetazolamide, tolvaptan, and ultrafiltration. Your time starts now. Okay, let us see. See, the Edward was the trial of acetazolamide in acute decompensated heart failure with volume overload. We know that the heart failure induces a state of increased proximal renal absorption. Loop diuretics, which is the treatment of choice, but this loop diuretics work distally in the loop of Henle. Even thiazides and MRAs act distally in convoluted tubules. Acetazolamide, which is a carbonic anhydrase inhibitor, it reduces proximal tubular sodium reabsorption, where SGLT2 inhibitors also work in proximal tubule at same place with different receptor. This molecule works, and it improves loop diuretic efficiency. The effect was studied in this Edward trial. So again, it was a multi-center RCT of more than 500 patients with acute decompensated heart failure with clinical signs of volume overload and raised NT-proBNP. Patients were randomized to 500 mg of IV acetazolamide given for 3 days or placebo. Nearly 90% had NOHA class 3 to 4 heart failure. Follow-up was 3 months. Patients with eGFR of less than 20 and those treated with SGLT2 inhibitors were excluded. Mean EF was 43%. Majority were on guideline-directed medical therapy. So primary endpoint of successful decongestion with acetazolamide for 3 days was achieved, and that was highly significant. Even at the time of discharge, decongestion was significantly more when you use acetazolamide. So message from this trial was also clear. It concluded that the addition of acetazolamide to loop diuretic in patients with acute decompensated heart failure resulted in greater incidence of successful decongestion. It leads to more diuresis, more natriuresis, and shorter hospital stay if you give. And number needed to treat was just 6 only. So correct answer is 12/10. Your audience is right. Another question, in management of heart failure with fluid overload, torsemide is better than furosemide. Furosemide is better than torsemide. Continuous IV infusion is better than round-the-clock boluses. Combination of both is even better, or both are equal. Time starts now. So, okay, let us see. So this transform heart failure was a trial of comparison of torsemide with furosemide for management of heart failure. Theoretically, torsemide has better oral bioavailability, longer duration of action, and has anti-aldosterone and anti-fibrotic effect on myocardium, which may give better clinical outcome. So it was a multi-center RCT of nearly 2,900 patients who were hospitalized for heart failure and treated randomly with torsemide or furosemide. Follow-up was 17 months. 2/3 patients had heart failure with reduced ejection fraction and rest had heart failure with preserved ejection fraction. Majority were on guideline-directed medical therapy. Primary endpoint of all-cause mortality was no different. And even composite of all-cause mortality and heart failure admission was also similar. So message from this transform heart failure trial was clear. Torsemide and furosemide had similar clinical effectiveness for CV mortality or heart failure hospitalization. So correct answer to this is both are equal, nothing is superior. So again, we learn something. I will present one more trial. So what is take-home message from these 4 trials? DELIVER trial showed us that among patients with heart failure with EF more than 40, raised NT-proBNP, regardless of diabetic status, dapagliflozin significantly reduced composite of CV death and heart failure hospitalization. Meta-analysis of SGLT2 inhibitor, actually to provide power to assess mortality benefit, meta-analysis of 5 RCTs of SGLT2 inhibitors comprising of more than 21,000 heart failure patients with entire spectrum of ejection fraction was done. And it showed clear and significant benefit of SGLT2 inhibitors, not only for composite of CV death and heart failure admissions, but also for CV mortality and all-cause mortality. So this should be there as a first pillar in every patient with heart failure, regardless of presence or absence of diabetes. Edward was a trial among patients with acute decompensated heart failure and clinical signs of volume overload and raised NT-proBNP, addition of IV acetazolamide, that is carbonic anhydrase inhibitor, which reduces sodium reabsorption in proximal tubule, resulted in significant diuresis, natriuresis, and decongestion. And transform heart failure trial among hospitalized patients with heart failure due to any cause, torsemide and furosemide had similar effects on all-cause mortality and heart failure admissions. There is some time, I will present one more slide. Empagliflozin and kidney. This is a question again. It is effective even if GFR is less than 15. Increases eGFR immediately and thereby causes diuresis. Improves renal outcome on long term. DAPA is better than EMPA for renal outcome. Benefit is seen only in patients with diabetic kidney disease. All of the above are correct. Here C is the highest opinion. Let us see. So the EMPA kidney was a multi-center RCT of nearly 6,600 patients who had CKD grade 2 to 4 with eGFR of 20 to 90. Nearly 54% patients were non-diabetic and follow-up was 2 years. Mean eGFR actually was 37. 86% were on RAS inhibitors, and primary endpoint of composite of CV death and progression of kidney disease was reduced by 28% with EMPA, and that was highly significant. If we analyze secondary endpoints of all-cause admissions, benefit of EMPA was seen in all pre-specified subgroups, regardless of diabetes status, level of eGFR or USER, or presence of cardiovascular disease. So again, among wide range of patients with CKD, regardless of diabetes status or level of eGFR, EMPA reduced the risk of progression of CKD and CV death in patients with CKD. So correct answer is again improvement in renal outcome. So here at last ultimately audience is correct. Thank you.
And I shall walk you through some basic concepts in management of thoracic aortic disease. As cardiologists and internal medicine doctors, we are going to be seeing a lot of these patients, whether we like it or not, and so it is important for us to have an understanding of this. So, love may or may not last forever, but if you have aortic disease, it's a lifelong disease. It will stay with you forever. So, this is sort of like your retirement account. You need a long-term plan. Okay? You may be dealing with patients in their early stages of aortopathy where you just continue watchful waiting. Hopefully, if you do your job, you do not have to deal with patients who present with an acute emergency. So if you have a game plan, you are not going to deal with an acute emergency. But, like it or not, you will be dealing with patients that present with an acute emergency. There will be people who present with late degeneration of disease that you're following. And of course, there's always family members that you have to screen. Every thoracic aortic disease, you need to screen first-degree family members, especially because these run in families. I will contend in 2023, a well-managed patient with thoracic aortic aneurysm will get identified and operated preemptively. If you do your job right, if we do our jobs right, there should be no acute aortic emergencies, because then the clock is ticking and it's sort of like playing the lottery and you may or may not be successful. So it is difficult to ascertain the true incidence of thoracic aortic aneurysms, but the etiology is thought to be a common form is genetic mediated syndromes like Marfan's, Loeys-Dietz, Ehlers-Danlos syndrome, non-Marfan but familial, truly familial disease, Turner syndrome. Bicuspid aortic valve is another common presentation, and about 40 to 50% of patients with bicuspid aortic valve have a concomitant aortopathy. Obviously, some of the rarer causes are inflammatory vasculitis, atherosclerosis. Now, atherosclerosis can exist concomitantly with thoracic aortic disease, but generally, it is not the primary cause of thoracic aortic syndromes. And obviously other risk factors, the standard comorbidities add fuel to the fire. If you look via genetic testing, 5% patients have documented genetic syndromes, but about 20% of them have a familial aortopathy, and we just have not yet discovered the genetic mutations. These are two cases of both with bicuspid aortic valve, both my patients. The first one on the left is a bicuspid aortic valve. The valve looks totally normal, no AS, no AR, but patient has an aortic aneurysm. The flip side, this is a patient, again with a bicuspid aortic valve, very eccentric, posteriorly directed jet of severe AR and a normal ascending aorta. So different flavors of the same disease. So if you have a patient with a bicuspid aortic valve, they should at least have one tomographic scan to look for concomitant aortopathy. Echo is the mainstay, not mainstay, but the first-line diagnostic modality. But the key message here, as you deal with aortic aneurysms, is accurate assessment of aortopathy, accurate imaging. Echo is good, but it has challenges. Echo relies on measurements. It does not account for eccentric dilation, and there is problems how the data has been acquired over the years, or how the normative data is ascertained using echocardiography over the years. It is also getting more and more clear that there's an association with height and body surface area as to what constitutes normal aortic dimensions. So I will contend, another contention in 2023, if you know that your patient has a suspected aortic disease, they should have at least one tomographic scan to prove or disprove. And if you have an aneurysm, then they need a plan of serial follow-up. So the gold standard, in my opinion, assuming normal kidney function today, is a gated contrast-enhanced CT angiogram. Important. Every word here is important. Gated, contrast-enhanced CT. What does gating mean? It means that the signal is triggered off of the patient's ECG to reduce the presence of artifacts. The biggest problem when you are measuring aortic aneurysms is artifacts due to breathing and cardiac motion artifacts. These have to be accounted for. Technology exists today to avoid having this, because there's nothing worse than a bad decision made on wrong data. If CT is not feasible, there are techniques using cardiac MRI that you can use to measure aortic size as well as other pathologies. A right and a wrong way of doing things here. I put things like that not by mistake, that is deliberate. Okay? So this is a patient that was sent to us, auto-launched helicopter with acute type A aortic dissection. That's the outside hospital image. All we did was we fixed his dissection by gating the CAT scan. This is important. You do not want your surgeon to call you after a sternotomy and a normal-looking aorta. This is another example. Too often, our friends in radiology like to just report measurements on axial images. That is not right. If you just report standard axial measurements, this person would have an aorta of almost 12 centimeters. If you just reconstruct the way you're supposed to do in 3 dimensions, it is not the case. You do not want to make a wrong decision based on suboptimal data, or even worse, suboptimal interpretation. As I alluded to, there's emerging data that size of the aorta, normal size of the aorta, varies based on patient's height or body surface area. Now, body surface area changes over the years, so we believe that indexing somebody's aorta to their height is a better way of counting apples and apples and not confusing between apples and oranges. So this is a couple of papers that we have published over the years, which have shown that if you do the aortic measurement and index it to the patient's height, it provides a lot better risk stratification compared to just reporting standard measurements. What is medical therapy? I would contend the most important thing that can be done is referral to an experienced center which has a full spectrum of advanced imaging as well as surgical therapies available. Blood pressure control is crucial. There is emerging data, especially in the context of Marfan syndrome, where a beta blocker plus angiotensin receptor blocker, ARBs, provide incremental value to a point where it delays progression of disease and need for surgery. You obviously have to be aggressive about the blood pressure as well as heart rate, so impulse control is crucial. Statins have been shown to reduce events in abdominal aneurysm, but not necessarily in thoracic aneurysm, because there the issue is mostly genetically driven. Busy slide, but just key points here. If you have a documented symptomatic ascending aorta, they need to go for surgery. If your aorta is asymptomatic and it reaches more than 5.5 centimeters, proceed to surgery. If the diameter is less than 5.5 centimeters, but it is growing rapidly, proceed to surgery. The question happens when you have an aorta that is at 5 centimeters or less. First of all, you have to be accurate about the measurements, but more importantly, if you index it, we have found that especially in shorter individuals, shorter females or shorter men, you are better off indexing it to their height, and if you do that, and if the ratio is more than 10 centimeters per meter, then it is appropriate to send them for a preemptive surgery. Remember, these are now guidelines. This guideline data was influenced by our research. This indication came in the guidelines after we published our paper from the Cleveland Clinic. So it is, and if you are undergoing a cardiac surgery for other reason, and if your aorta is more than 4.5 centimeters, you should get it concomitantly fixed. Arch aneurysm, similarly symptomatic, the same concept applies. Low operative risk, asymptomatic, more than 5.5 centimeters. High surgical risk, then you could consider hybrid approach. Of course, you need to be looking for an experienced center. Descending aorta, less than 5.5 centimeters. If you have average operative risk, but at an elevated risk of rupture, go for it. If you have advanced comorbidities, then typically most folks wait till 5.5 centimeters, and there's emergence of endovascular stent therapy for these kind of patients. Experience matters. I cannot underscore the importance of that. The image on the right is mean annual surgeon thoracic dissection volume, and the y-axis is talking about mortality. Less your experience, higher the mortality. This is Cleveland Clinic numbers. We do about 12 to 1,300 aortic surgeries a year. The expected mortality is 3.8%. Our observed mortality is 0.3%. So experience truly matters in this situation. This is one of the main reasons why you do not want to find yourself in an emergency. You fix the problem before it becomes an emergency. Surveillance, if you have Marfan's, you need a full body CAT scan, and you need to follow it up annually. If it is stable, if it is not stable, then you may need to do it sooner. Bicuspid aortic valve, again, you need to document aortopathy. If you have no aortopathy, then you can repeat it every few years. Turner syndrome, and so on and so forth, it keeps going. The bottom line is you need accurate measurements at baseline, and then you need to have a game plan of following it periodically, preferably in the same center, preferably comparing the data. There's nothing worse than scaring the patient with the wrong information. Genetic screening, Obviously, as I alluded to, only 5 to 10% people are gene positive. If they're gene positive, then their first degree relatives need to be screened. If they're not gene positive, then you are relegated to doing imaging-based serial follow-up. Physical activity, isometric exertion, so grunting and lifting beyond their body weight, beyond 50, 70 pounds is what I typically recommend. Is not a good idea, but it is absolutely important to realize you should not curtail aerobic activity. Nothing worse than getting the patient deconditioned and developing comorbidities of hypertension, obesity, etc. So aerobic activity, not a problem. It is important to screen for anxiety and depression because a lot of these patients, you're going to scare the living daylights out of them by telling them the diagnosis, and then they stop working, they get depressed. You want to be careful about all this. Another important thing, this is important. This is not a surgical disease after the initial surgery. This becomes our problem. These patients come to us every year. So you, the internist, you, the cardiologist, need to know what your patient has had, and then you should be anticipating potential complications and looking for, you need to be knowing what you're looking for when they have their follow-up scans. So if you had a patient with a valve-sparing aortic root replacement, you need to look at the aortic valve. If the action is supracoronary graft, you need to look for infection of that graft. If it's a full-on Bentall procedure, you need to look for the aortic valve as well as action downstream. So it is important that we, the non-surgical physicians, are aware of what they've had and have a game plan of following these patients periodically. Shared decision-making is important. You are potentially talking about sending a patient for a preemptive operation. They need to know. They need to know what the outcomes are of your program. They need to know what they're getting themselves into. They need to know family screening. They need to know what is there for their children, their siblings, etc. So to conclude, aortopathy is a lifelong disease, so you need to have a game plan of dealing not only with the patients but first-degree relatives. This requires, cannot underscore, it requires meticulous imaging and a long-term game plan. Thank you so much.
This topic is a little different. I'm not going to show many ECGs in this. This is more about artificial intelligence in arrhythmia and heart failure. Artificial intelligence, you've heard of this term. We never thought it would enter the medicine or our practice, but it is pervading everywhere now, and it's entering for sure. So I'll give a brief introduction about artificial intelligence, but more importantly, I'll talk about how it is being applied in EP, in arrhythmia, in heart failure. And we are going to see more and more of this in the next few years, in the next decade or so. Dr. Neil Mehta had given a lecture on this year back. So artificial intelligence refers to machine-based data processing to achieve objectives that typically require human cognitive function. So essentially what we used to do previously using books and all, the computers did a majority of work in the last, in 2-3 decades, the computers took over. In the same way, a lot of our human brain processing is going to be done by artificial intelligence. In the modern era, AI has mined dense data, a lot of data, and provided the potential to classify complex patterns and novel representations of data beyond direct human interpretation. So things which are so huge, an amount of data that our brain cannot process easily, artificial intelligence is doing it. So this term came actually in 1956, Dartmouth's summer research project, where they said, they coined the term artificial intelligence on the assumption that human intelligence can be so precisely described by a machine that a machine can be made to simulate it. So we are talking about data science, artificial intelligence, analyzing part of the data, machine learning, deep learning, you've heard of these terms, and big data, the data which is immensely nowadays available in huge amount. We have to learn a new language. I'm not going to go take you through this in detail, but you should be aware of this. So machine learning. this was defined again in 1959 by Arthur Samuel, who stated, programming computers to learn from experience should eventually eliminate the need for much of this detailed programming effort. So what humans do the programming, all our software engineers in the US, in Intel and all, they created all these programs and made the computers learn it. Here the computers would be doing it by themselves. And in machine learning, AI systems learn from the data that they are provided, complementing the original ideas of encoding intelligence into the AI system. It all sounds like physics and futuristic, but it's being applied in medicine. Three more terms: supervised and unsupervised machine learning. So supervised learning is where the machine is provided a set of labeled images which are truth, which are defined by us. For instance, ECG labeled as sinus rhythm or atrial fibrillation, and then the machine is, the computers are made to learn that this is sinus rhythm, label all future ECGs like sinus rhythm. Unsupervised machine learning methods build the features set by themselves, surfacing whatever they find of significance. The machine model may organize itself to find clinical factors in patient history that lead to greater propensity for sudden cardiac death. See the direct application here. And then this, when the machine sees the pattern, it reinforces this learning. Like certain drugs may work better in certain patients in certain diseases. So that is unsupervised learning. Deep learning is another term. It employs artificial neural networks, like we have synapses. So artificial neural networks inspired by structure and functioning of human brain. This is especially useful where images are involved, like brain MRI images or cardiac MRI images, and a lot of pathology images. Each layer is like a step in a series of analysis, performs a task which is propagated to the next layer in the network, and that creates artificial neural networks or convolutional neural networks. So this is one layer, then they interact with each other, next layer. So things like this, you can actually, there is an output of prediction score of cardiovascular mortality or prediction of LV dysfunction. So this is all sounds alien, but it is directly applicable to us, and in future it's going to be more applicable. And this is moreover coming up very much in imaging, looking at abnormal cardiac tissue, myocardial scar, atrial scar, and that has a direct bearing on ventricular arrhythmias or atrial fibrillation, etc. Now, artificial intelligence in electrophysiology presents a unique opportunity because the device industry, we implant pacemakers, ICDs, CRTs, and they are they store a huge amount of patient data, their heart rate, their arrhythmias, and they will be able to make superior predictions about progression of atrial fibrillation, about ventricular storms, about ventricular arrhythmias, or risk of sudden cardiac death in a patient. And where is the data coming from? Our everyday use, smartwatches, wearables, mobile phones, ECGs, computer modeling and simulation, and even our electronic medical records. And this is through machine learning, deep learning, we can get actually information about enhanced disease detection and diagnosis, say for atrial fibrillation, or predicting outcome like CRT response of heart failure to CRT implant, or even new things that we are not even aware of now, like linking fibrosis in atrium to atrial fibrillation. The very basic ECG itself is more than 100 years old, but advancing in computing power and availability of digital data will have even more information coming out of our ECGs. So it can take care of the basic stuff like do human-like tasks like standard ECG connotation or diagnosing arrhythmias, but it can also add value like physiological signals for risk stratification of sudden cardiac death can be obtained from artificial intelligence. And they are looking at discernible patterns in ECG, so it is able to see beyond human capability. Artificial intelligence will perform human-like ECG interpretation And that can be done by looking at single lead like we get from our extended loop recorders or 12 lead ECGs. And it is able to now detect, looking at an ECG, what sex is the patient, is it male or female, and approximately even what the age of the patient is likely to be. So more exciting things coming up. There are certain ECGs, certain diseases that may not have a pathognomonic ECG pattern, but it is able to, with artificial intelligence, predict that this patient is likely to have one of these: amyloidosis, pulmonary hypertension, aortic stenosis, hypertrophic cardiomyopathy, AF risk, concealed long QT syndrome, in COVID-19, or even low EF. So these are very real applications. So quickly I will go through some of these very obvious application of artificial intelligence's rapid, reliable, automated determination of ECG diagnosis. Already there is 12 different rhythms have been classified by looking at ECGs. It can also confer information about disease not typically diagnosed on ECG, like I said, like amyloidosis or so. And this will add value to a routine test. We are all aware of how ECG pattern changes with potassium level. They are one-to-one relation and it's exquisitely connected. But even more subtle potassium changes may be detected by deep learning of the ECG. And this has direct implication because you may be able to do outpatient titration of medications that disrupt the potassium level, or you can even schedule dialysis looking at the information that you get. If the potassium is going up, even without doing a blood test, you may be able to advise that the patient should undergo an early dialysis. Myocardial diseases causing poor function affect the ECG, but ECG is not a good screening test for asymptomatic LV dysfunction, which may be present in 5% of the patients. So these networks trained using ECG or echo could reliably detect LV dysfunction. Analysis of sinus rhythm ECG can predict paroxysmal AF in a patient. So recognize ECG patterns to diagnose AF while the patient is in sinus rhythm. This may be useful if a patient of stroke of unknown origin, young patient, or any other person who's had, where you're suspecting atrial fibrillation but it's never been recorded. But if you can predict that this, the predilection for atrial fibrillation is there in a patient who is presently in sinus rhythm, you can decide regarding anticoagulation for this patient. So, like I said before, AI can be used to predict sex and estimate age to an error of like approximately 7 years. And look at the application. Patients whose AI predicted age exceeded the actual age by more than 7 years had a higher proportion of low ejection fraction, hypertension, and coronary artery disease. So how things are getting linked, that looking at an ECG, AI says, oh, this patient is likely to be 56 years old. But the actual age, if it is 45, that means it is exceeding by more than 7 years. That patient is likely to have multiple other diseases. So AI interpretation of age based on ECG may be a mechanism to measure overall health. Mortality. The convolutional networks to predict 1 year mortality from ECGs, even among ECGs that were interpreted to be normal by physicians. So you're looking at a normal ECG, but you can predict the mortality rate of a given person. Like I said before, all these cardiovascular implantable devices that we have, pacemakers, ICDs, CRTs, they have a wealth of data, and in particular in CRT and ICD, we can look at variables that are known to correlate with worsening heart failure, like onset of atrial fibrillation, and propensity for atrial or ventricular arrhythmias. Prediction of ventricular arrhythmias can be done by just looking at these electrograms, the information that we get from these devices. The pacemaker alerts that are given by these devices for arrhythmias or parameter abnormality can also be picked up by this. Application in ablation, what we do routinely, When we do ablation, we are eyeballing the electrograms, looking at certain parameters. We want to define these parameters better, but they are fairly limited. But the amount of data that is available to artificial intelligence, now multi-parametric non-linear models can be created that can predict the site of ablation and what the outcome would be much better. Even in atrial fibrillation ablation, when it was combined with, we do pulmonary vein isolation for paroxysmal AF or persistent AF. And this is more or less based on experience on the new mapping systems, what we can interpret. But here, looking at this data, they are able to predict the outcome much better. Personalized virtual heart model can be created. It's like a digital twin of patient's heart, and then that can assess the arrhythmogenic propensity of the patient. So patient has had a previous anterior wall MI, there is some amount of fibrosis. You do a cardiac imaging, create a model, and then the artificial intelligence can predict whether this patient is prone to ventricular arrhythmias or not. And precision medicine, what Dr. Neil Mehta talked about in the morning. This has again direct application. You look at genome sequencing, genetic basis for cardiovascular arrhythmia disorders, and you can have direct treatment or treatment models for these type of patients. So imaging here for 45 patients of MI, you're simulating arrhythmias, you can predict propensity for arrhythmias and what likely treatment is going to be. Of course, a lot of limitations, we are all still learning. We need to increase the accuracy, generalizability of this. Algorithms work well sometimes during the training period for testing, but when you're actually applying it, it may not fit well. There are certain assumptions, etc., which we need to be careful about. So following terminologies are connected to AI: machine learning, deep learning, supervised machine learning, unsupervised machine learning, all of the above, all of the above. And AI is being researched in the following: ECG analysis, sinus rhythm analysis to predict AF, age, sex parameters, mortality estimation. Yeah, all of the above. Let's go to the next one. Just a minute, 1 minute. Let me just summarize. Artificial intelligence, machine learning have significantly impacted the field of cardiac EP. Wearables, smart devices, and our implanted devices provide a lot of information, and it can actually identify sites of successful ablation and predict response in ablative therapy. And personalized computation modeling will also be something that we have to look out for the future. Thank you.
So we know that cardiovascular disease is the top leading cause of premature death globally, and 10% of global disease burden is because of the cardiovascular disease, and they claim more lives than all forms of cancer combined. And lipids are one of the most critical cardiovascular risk factor for acute MI, as you can see from this chart. And yesterday also we discussed that LDL cholesterol effect is cumulative over time. Suppose a person has got low LDL from very early age, he is less likely to have cardiovascular disease than the person who has got higher LDL level from very early age. Now, absolute LDL cholesterol lowering is also correlated with relative risk reduction in cardiovascular event, and 1 millimole, that is 39 milligram% reduction in LDL cholesterol, was associated with over 5 years with 23% reduction in major coronary events and 21% reduction in the major vascular events. So it's a huge difference. And raised LDL is observed in up to 70% of the CAD patients in India, but unfortunately only 1/3 of the patients, they achieve target LDL cholesterol. And several studies have shown that there is a quantitative linear relationship between LDL cholesterol level and cardiovascular events. And every, as we discussed, 40 milligram percent decrease in LDL cholesterol, there is a relative decrease of CV events by 20 to 25%. Now, what does the guidelines recommend? So, ESC guidelines have identified a very high risk category of patients, and these patients include patients with documented ASCVD, that is patients having previous ACS, stable angina, patient who has undergone PCI, CABG or other arterial revascularization procedures, patients has history of stroke, TIA and peripheral arterial disease, patients who has got significant plaque on coronary angiography or CT angiography, that is multivessel disease with two major epicardial arteries having more than 50% stenosis, or patients showing atherosclerosis on carotid ultrasound, patients with diabetes with target organ damage, patients with type 1 diabetes with long duration, that is more than 20 years, and patients with severe CKD, and also patients who are high risk and having calculated score of more than 10% for the 10-year survival risk. And in these patients, the target LDL is now less than 55 milligram percent and 50% of the reduction. So there is a change from 2016 guidelines, and the now guideline says that you have to achieve the target of 55 milligram percent or less, and also there should be more than 50% of LDL reduction than the baseline in this very high risk category of the patients. So the guideline recommends that there should be a pharmacological LDL lowering in this very high risk group of patients with high intensity statin prescribed up to highest tolerated dose to reach the goals. It is a class 1A indication. If the goals are not achieved, you add ezetimibe to statin, and still if this target is not achieved, then combination with PCSK9 inhibitor is recommended, and it is now a class 1A indication. For patients who are intolerant to statins, PCSK9 can be given, but it is class 2B indication. So for acute coronary syndrome, all ACS patients should be given high dose statin irrespective of statin level, and then these patients should have lipid levels re-evaluated 4 to 6 weeks after the treatment is started. If the levels are reached, that is fine. If the levels are not reached, you add ezetimibe, and still if the levels are not reached after 4 to 6 weeks of adding ezetimibe, then you have to add PCSK9 inhibitor. For patients who present with ACS and whose LDL cholesterol goal levels are not at goal, despite already taking a maximum tolerated dose of statin and ezetimibe, the addition of PCSK9 inhibitor can be started early after the event, even during hospitalizations for ACS patient if possible. And this is for the first time it has been incorporated into guideline as a class 2A indication. And they have also suggested that patients with ASCVD who experience second vascular event within 2 years and not necessarily of the same type as the first event while taking maximally tolerated statin-based therapy, LDL cholesterol goal of less than 40 milligram percent should be considered. So highlights of these guidelines are more intensive LDL cholesterol reduction across all CV risk categories. PCSK9 moved from class 2B to class 1A, the highest possible level of recommendation for secondary prevention. No lower limit for LDL cholesterol values. The lower is better. Very, very important message. And very high risk patients has been identified. Only LDL cholesterol goals recommend, not thresholds. So very high risk, more than 50% LDL cholesterol reduction and LDL cholesterol of less than 55 milligram percent. And recurrent event, as I said, you can consider LDL cholesterol less than 40 milligram percent. Re-evaluate lipids at 4 to 6 weeks. Again 4 to 6 weeks later, if goals are not reached with statin and ezetimibe, add PCSK9 inhibitors. And for the first time ever, ACS patients, they have recommended to consider PCSK9 initiation as early as in hospital for patients already taking maximum lipid lowering therapy. Now existing therapy has limitations. We know statin tolerance is not uncommon. Ezetimibe is a relatively weak drug. and this bile acid sequestrants and nicotinic acid, they are poorly tolerated. So there is unmet medical need for a potent, effective and non-statin agent that will lower LDL cholesterol and reduce cardiovascular risk in high-risk patients unable to achieve optimally low LDL cholesterol, patients with heterozygous familial hypercholesterolemia, and patients who has got statin intolerance. And and we know that PCSK9 is a regulator of LDL metabolism. So this molecule, which is secreted by liver into plasma, binds LDL receptor on surface of hepatocytes and targets LDL receptors for degradation. So this PCSK9 binds to LDL receptor, and there are fewer LDL receptors on hepatocyte surface, which results in increased plasma LDL cholesterol. So with this PCSK9 inhibitor, we can increase these hepatocyte surface receptors, and the LDL cholesterol can be decreased very effectively. Dose, it is given as a 140 milligram every 2 weeks or 420 milligram once monthly. And that phase 3 trials have showed that there is, approximate reduction of 50 to 60% with this evolocumab therapy, whether it is given in combination therapy, monotherapy, it is given in heterozygous familial hypercholesterolemia or in statin intolerant patient. And as far as the effect on lipid parameters are concerned, it consistently reduced pro-atherogenic lipid parameters and modestly increases HDL cholesterol. As far as the outcome is concerned, there is an incremental value. Lower the LDL value, lesser the event, as you can see. And this was the 4-year trial, which was a landmark trial, very large trial, more than 27,000 patients. And they randomized patients having LDL cholesterol of more than 70 or non-HDL more than 100 milligram percent between evolocumab and placebo, and followed up to 12 weeks. And the trial showed that LDL cholesterol was reduced by 59%, decreased severe outcomes in patients already on statin therapy, and it was safe and well tolerated. And as we discussed, there is incremental benefits with LDL cholesterol reduction in primary endpoints. Lower the LDL, better the outcome. And particularly, certain high-risk categories, the results were, even better. For example, patient has history of MI less than 2 years, risk reduction was much better. Patients with higher, with more than 2 prior myocardial infarctions, again, this drug was better. Patients having multivessel disease, the outcome was superior as against patients who are not having multivessel disease. As far as safety data is concerned, there was no concern, no difference between evolocumab and placebo, as you can see. As I said, the highest risk, highest benefit was noted in this trial, and patients with highest starting LDL cholesterol and patients who has got higher risk, as we discussed, they got the maximum benefits. And these are the patients having ASVD with diabetes with or without CKD, ASVD with CKD, patient having recent ACS of less than 3 months, poorly controlled risk factors and CHD, CHD and peripheral vascular disease, CHD and age more than 65, patients having history of stroke, TIA, male patients, and CHD with familial hypercholesterolemia. So we will discuss some cases. 46-year-old male, clinical history, known case of hypertension, diabetes and dyslipidemia, multiple risk factors. First MI 2013, second MI 2017, the same territory. 2019, again STEMI in another territory, that is LAD territory. Lipid profile, HDL 38, LDL 87. He was on 40 milligram statin. Will this patient benefit from further lowering of LDL? The answer is yes, because patient is having recurrent MI, multiple CV factors, on statin, LDL 87, and as we discussed, recommended levels less than 40 milligram percent. Lowest is the best, and evolocumab with statin will definitely provide benefit in risk reduction in this patient, as this patient is very high risk with recurrent events. So, and these are the data we discussed, incremental value of lowering the LDL level, and patients having more than 2 prior MIs has more benefit. This is another patient, 57-year-old, known case of hypertension, dyslipidemia, progressive diffused atherosclerotic disease pattern, multiple lesions, patient having multivessel disease, presented with chest pain and ACS, statin 80 milligram, ARB 40, multivessel disease, high intensity statin, multiple risk factors, presented with event, and evolocumab will surely provide benefit along with statins in achieving target LDL goals as well as the CV risk reduction. As you can see, multivessel disease has more benefit with this drug. Third patient, 52-year-old male, admitted in ICU 7 months ago with chest pain, diagnosed with ACS, 90% lesion in RCA found, PCI done, statin 80 milligram continued for 2 months, LDL still at 100 milligram percent on statin. Current scenario in the first follow-up test showed LDL 104 milligram percent. He is on statin 80 milligram. So patient is number one, recent MI, already on high statin, still LDL 104, recommended less than 55%. So this patient needs PCSK9 inhibitor because the patients with recent MI has got even higher benefits. So PCSK9 inhibitors for whom? Patients with high risk, they benefit the most. So if your patient has got recurrent MI, prior event within 2 years, more than one prior events, multivessel disease, ACS patient, including in patients use if not targeted LDL goals, even after taking maximum tolerated of this lipid lowering treatment, you have to give these PCSK9 inhibitors. And also with familial hypercholesterolemia and statin intolerance, this drug is indicated.
I change the topic, not yourself, but myself actually, CABG and myself. Let us try on myself first. I wish you guys never require CABG. So we will discuss about the two modalities which is available right now worldwide in India. So goal of the CABG, first of all, we need to have a complete revascularization of the area of myocardium, which is perfused by a coronary artery with more than 50% of stenosis. And in India, routinely 99% of CABG is being done by two ways, that is conventional stenotomy and left thoracotomy. There is a 1% missing is a hybrid CABG, which I am not going to mention here. What is conventional stenotomy of CABG or off pump CABG, off CABG, whatever we say? So that is a midline stenotomy, as we all know. That is a very standard, been practiced since last 55 years now. So we incise the sternum, we incise the pericardium, and after that we perform the surgery. Another one is left thoracotomy, which is now been practicing since last 12 to 15 years in India and almost 20 years in worldwide. So we put a small incision on the left side of the thorax. We expose the part of the heart to perform the surgery. And today we are just going to discuss these two modalities, merits and demerits, and after that we must decide according to. So there are a lot of factors actually we need to consider before selecting the patient for the type of CABG. For example, unstable angina, patient is having cardiogenic shock or not, renal insufficiency, neurological issues, preoperative instability requiring IABP, diffuse coronary artery, which is most common nowadays, particularly Indian sector, multivessel coronary artery disease, left main CAD, chronic total occlusion, obesity, associated pathology, like so many patients now, they have CCALV with mitral regurgitation or aortic stenosis, ASD, and LV dysfunction. There are many more things actually we check before we decide which kind of CABG we should offer to the patient. So let us have a comparison between off CABG and mid CABG. First of all, incision, as I said, there is a 10 to 15 centimeter long midline stenotomy, where in mid CABG we have a 5 to 7 centimeter long left lateral thoracotomy in 4th or 5th intercostal space anteriorly. Technique, conventional CABG is less complex. Whole heart is in front of us, so we can do anything. There is a steep learning curve required in mid CABG because the area of exposure is very limited. So we need a lot of precision. Mortality and morbidity in general in off CABG, off pump CABG is low, which is debatable as off pump CABG because long-term data is not available yet. Graft patency is certainly good because of the conventional method, There are some chances of error in case of a mid-cab CABG, particularly when the artery is small and when we try to do the posterior grafts. Revascularization, as I said, complete. In some cases, it could be incomplete because of a limited exposure. Sometimes small arteries, which we normally do when we have a stenotomy, so many centers, they escape these small arteries. Number of blood transfusion are more in off CABG in report-wise, but in good centers, the transfusion ratio is quite low as compared to mid-CABG. Recovery and pain is more or less same. Most important is infection. There is a 1.5 to 2% chances of mediastinitis when we do with the off CABG or stenotomy, which is not there with the mid-CABG. So infection rate is quite low in case of a mid-cab. And other limitation, as I discussed, associated pathology or LV dysfunction, neurological or renal issues. Off-pump CABG we can perform safely whenever it is indicated. There is a limitation with the mid-cap CABG. Advantage, I said, it is a complete revascularization. We can do as many S grafts we want to perform. It is less complex. Co-pathology, as I said, can be taken care simultaneously. Choice of surgery in emergency. In emergency, it is a midline stenotomy by default anywhere in India or worldwide. Surgical plan can be changed. So many times we have to change the plan. Like if there is a problem with the conduit, or there is LV dysfunction, if I have to put some IABP machine or ECMO kind of things, then midline stenotomy is always useful. And emergency issues can be handled very promptly, perfectly, when we have the whole heart open in front of us. Against mid-CABG having a certain advantage, I said, less chances of infection, less pain. Nowadays, it is okay. Less blood transfusion, that is also okay as compared to off-pump CABG. Less neurological and renal issues. Now, because of the case selection, most of the centers, they have a very good case selection. All patients perfect, then only they perform, and that's the reason there is a less renal issues. Cosmetics, certainly, particularly in female woman patient where the small incision comes underneath the breast, which is merely invisible. And less hospitals, say, again, it is a question. Nowadays, there is no much difference between the both technique. Now, this is most important, actually. According to me, incision never matters, whether it's a midline stenotomy or thoracotomy. The most important are conduits in CABG. As we all know, we have 3 conduits available in our body, which can be used in most commonly. There is a lima, left internal mammary artery, and right internal mammary artery, radial artery, and saphenous vein graft. There are some other conduits are there, but we seldomly use them. So patency rate, if you check at a 1 year and 10 years for lima is the best, 98% and more than 90% respectively. So lima and rima are the best conduits, followed by radial artery having the patency rate of 90% and 60% at the end of 1 year and 10 years respectively, and followed by SVG, where 80 to 90% SVGs remain open after 1 year. After 10 years, only 50% of vein grafts remain open. So selection of the conduit is very much important. I'll show you some data also. So this is a 10-year survival with 3-vessel disease. Lima was being used in SVG. So lima is having certainly advantage over SVG. This is one of the meta-analysis where the both internal memory was used, left and right. And there is a increased survival at the end of 12 years when we use bilateral internal memory artery in selected cases. This is another meta-analysis. In this study, one of my Sydney, where I was when I was there, actually, that center also was being enrolled. And if you see at the down, when we use bilateral internal memory artery, the results are better, outcomes are better. And as I said, radial artery is certainly better over saphenous vein graft. So whenever we plan for conduit, for any CABG, we have to justify, we have to use properly rationale, like, either lima, bilateral memory artery, radial artery, vein graft, according to the pathology. So these are the different configuration of conduits, as I said. And BIMA configuration is achieved in the best manner with the midline stenotomy. So again, I am telling you, whenever the matter comes for the precision or the revascularization, BIMA is best, not to consider incision, whether it's a midline or left thoracotomy. while performing through minimal invasive way, most center use radial artery and SVG as a second choice of conduit, which is certainly inferior to BIMA. So if we ask if patient is suitable for the BIMA, then I just use that way. Now coming to my angiography, here we can see that it's a diffuse disease, left septum. There is a LAD which is having a proximal lesion. There is a diagonal OM, last OM, RCA having a long segment lesion, and certainly cardiology colleagues, they have referred for the bypass surgery. So now question for you guys, after hearing this 7 minutes, which method you would prefer? Though you guys are clinicians, but at least you can answer that. So midline stenotomy, left thoracotomy, or medical management? Yeah, perfect. So it is a midline stenotomy, and this is the surgery of the same patient. Can we have a volume in here? No. Yes. So here we can see the Lima and Rima, which I made a Y graphs with them. So first we can see is Lima, Rima, Y. So we have attached Rima to the middle of the left internal memory artery, and then the first graph was done at diagonal with Lima, and the second graph was done is Lima to LAD. The third graft was done with the help of a Rima, that is high diagonal, and that Rima was taken down laterally to the OM, and the final graft was done on the BLB. So Lima, Rima, Y, and 5 grafts, that is diagonal, LAD, high diagonal, OM, and BLB. We have also done the 6th graft, which was put on PDA, and that graft was attached to aorta. This surgery was done on beating heart. There was minimum blood loss, and patient is doing very well. Thank you. So 6 grafts with a diffuse, that's what we get actually nowadays, because simple coronary artery disease has been tackled by our cardiology colleagues, and most of the time we get some diffuse triple vessel disease, long segment disease. So many times it requires end atherectomy or other procedures, CCLV. So we have to be very rational to use which technology is best for the patient. High risk factors for stenotomy, as I said, there is a 1.5 to 2% chance, that to get some deep sternal wound infection. Now that is one of the nasty complications. I admit that we don't like actually, but it still happens. Severely impaired left ventricular function or chronic kidney disease, carotid or neurological disease have some complication rate, but that is not comparable with the mid-cap. It is in general. Severe aortic calcification, where we use no aorta touch technique. Elderly patients, there are complications rate is slightly high. Mid-cap, what are the high risk is small target vessels, calcified target vessels, diffuse disease vessels, intramyocardial, emergency cases, patients with hemodynamic instability. These all are relative contraindication for the mid-cap age. So what is the rationale for the use? Patient benefit, as I said, less pain, less blood usage, early recovery, less painkiller use, less scarring, and facilitates redo surgery. If these patients need second heart surgery sometimes, then it is certainly easy actually to do through stenotomy. There are certainly challenges are there for surgeons. For us, it is a longer surgery time. It takes normal than the routine midline stenotomy off cap. Technically, it is difficult. Okay, we need special, steep learning curve, specialized training, equipment, always possibility of conversion to midline stenotomy that we explain. Any thoracotomy, we have to take a consent from the patient that this patient, if you have any technical issues, or if any hemodynamic instability, we have to convert to the midline stenotomy. And certainly it is slightly costly. So is mix for all? No. Subject of preference, either doctor or patient can say yes or no. Multiple pathology, gross peripheral vascular disease, associated acquired congenital anomalies, multivessel disease, small thoracotomy exposure, with grossly obese patients, these all patients we should say no to mix. Summary, complete revascularization is important and not incision, as I said. We need to do maximum graft which is required, and there we have to select the incision. Clean targets, few grafts, no other comorbidity. Mixed CABG is certainly preferable, and that's what we do. ERAS protocol, that is early recovery after surgery protocols, and beating heart outcome CABG has reduced blood transfusion rate, pain and overall recovery, which is in favor of midline stenotomy. Single most worrying complication of stenotomy is mediastinitis. As I said, if it happens, it is really, that's one of the most morbid complication. BIMA, more arterial grafts are always to be considered when anatomy is favorable, and that's what we do. At Marengo CIMS, we are doing pioneering work at mixed surgery with excellent results since last 12 years. So each and every patient we scrutinize whether this patient needs mixed CABG or conventional CABG. If patient demand, then we explain. If patient doesn't ask and if it is a favorable, then we explain to relatives that this is a better option. But we always give the best to the patient, considering complete revascularization. Thank you.
Today I'll be talking about CT coronary artery calcium scores with a case-based approach. I have no disclosures. So let me start with a recent conversation I had with my uncle. He asked me, my best friend just had a heart attack. I want to know if I'm next. He's 51 years old. His father had a heart attack with blockages at age 50 and then bypass surgery at age 66. His last doctor's appointment, his blood pressure was 145/87. His total cholesterol was 220, HDL of 46, LDL of 145, and triglycerides of 165, not on any medications. What he was asking me was, do I need a stress test or do I need screening? So what are the objectives of screening? To look for coronary artery disease and stenosis, that is diagnosis, and they want to know prognosis. So is the patient likely to die or suffer from a coronary event? What would you do next? No more testing to further stratify risk, an exercise treadmill test, an exercise stress echo, a coronary CTA, an invasive coronary angiogram, or a calcium score. So let's talk about the different options. We could have a patient undergo exercise stress testing. So about my uncle, he walks about 1 hour on the treadmill at a good speed, good incline. What if we had the opposite, a patient who could barely walk on the treadmill? Are we calling this a positive stress test or an abnormal stress test in heart disease, or is it just deconditioning and low exercise capacity? So the pitfalls of stress testing, it only detects significant coronary artery stenosis and does not identify non-obstructing plaques. Normal stress results on a stress test may falsely be reassuring. How about patients with a low pre-test probability of CAD? A positive stress test is likely to be false positive. Many people with false positive stress tests will undergo subsequent testing and intervention, like a coronary angiogram and possibly revascularization on something they may have not needed. And up to 3% of the patients who get stress tests undergo cardiac catheterization, and 1.7% of these may lead to severe adverse reactions. So I plugged his numbers into the ACC-AHA 2013 ASCVD guideline calculator and got a 10-year risk of having a stroke or a heart attack of 5.5%. We'll come back to my uncle later. Let's talk a little bit about calcium artery scores. So the calcium deposits in atherosclerotic plaque. It can be seen as early as the second decade of life when fatty streak formation begins. It appears as white spots on the images with a Hounsfield unit of more than 130. We can get a calcium artery score by doing 3 millimeter thick CT slices of the heart. The heart's usually 12 to 16 centimeters. There's automated software that highlights these areas of white spots in color. We calculate a combined volume, and density of coronary artery calcium, typically using the Accreditation method, which does need a dedicated computer software. On the top image, we have no coronary artery calcium. On the bottom image, we have the coronary artery calcium, which is highlighted. The coronary artery calcium scoring is a rapid method to exclude significant atherosclerosis, which takes about 20 seconds of breath hold. It requires no patient preparation in terms of no IV, no medications. The only thing required is EKG gating. The scanners are widely available. It can be performed with EBCT or conventional multi-detector CT scanners. The minimum slice requirement is 16. The quantification method is fairly standard, relatively low radiation exposure, about 1 to 3 millisieverts, with the newer technology less than 1 millisievert, which is about 2 mammographies. It can also identify non-coronary causes of chest pain, like hiatal hernias or lung pathology. It's relatively inexpensive, with an average cost of rupees 3,000 to 4,000, and the prognostic value has been very well validated. So let's go over interpretation of coronary artery calcium score. If you have a calcium score of 0, it indicates a very low risk of less than 1% risk of myocardial infarction or stroke at 10 years. 1 to 100 is a low risk with less than 10% risk of MI or stroke at 10 years. 101 to 400 is a moderate risk with 10 to 20% risk of MI or stroke at 10 years. 101 to 400 calcium score is more than 75 percentile and moderately high risk, which is 15 to 20% risk of myocardial infarction or stroke at 10 years. And more than 400 score is high risk with a risk of MI or infarction stroke at 10 years of more than 20%. What is the value of coronary artery calcium scoring in identifying high-risk ASCVD events? What do the current guidelines tell us? Let's go over the concept of de-risking. Are we over-treating our patients, and who do we need to de-escalate therapy on? This slide shows the ACC AHA 2019 guidelines of primary prevention. For patients aged 40 to 75, they recommend assessing the ASCVD risk percentage. So looking at the 10-year risk of my uncle, which was 5.5%, he would be in the borderline risk category. So next we want to look at the risk enhancers. Risk enhancing factors are mentioned here. The most important one for us is high risk race or ethnicity, which is South Asian ancestry, which was my uncle and most of your patients here. His calcium score was 43. When we plugged into the MESA calculator, he had a percentile for the calcium score was 79 percentile. Now the MESA calculator has a race ethnicity of white. There's a lot of subgroup analysis which happened in the original study with Southeast Asians that showed they had a similar risk as white, so it's okay to use white in this case. When you plug in the MESA score into the CHD risk calculator, you can further get another risk score. The next case is a patient who had a calcium score of 0. He then had a CTA, which had normal coronaries, so no obstructive CAD. So calcium score of 0 is typically indicative of normal or non-obstructive CAD, and this is the rule rather than the exception. However, calcium scoring does not provide information on the presence or burden of non-calcified plaque, which further requires contrast. So by using coronary CT angiography, non-calcified plaque burden has been identified as an important predictor of future adverse cardiac events, particularly among symptomatic patients. So if your patient is symptomatic, you don't want to rely on a calcium score. In 2019, the concept of power of 0 was introduced. This was a large review of over 85,000 patients that concluded that the absence of calcium in the coronary arteries was associated with a very low risk of future cardiovascular events and all-cause mortality. So let's look at redefining risk estimates for individual patients. So if your patient has a calcium score of 0, It's below the threshold for statin benefit, and you can consider avoiding or postponing drug therapy if there are no other significant risk factors. Next, let's go over coronary artery calcium score and coronary artery atherosclerosis. So this is a 52-year-old patient, male, with shortness of breath that was worsening. He had hypertension. His total cholesterol was 196. His LDL was 133. So he had a coronary artery calcium score of 224. He further underwent a CTA, which showed calcified plaque and non-calcified plaque both. You can see here that there's non-calcified plaque, which was significant. He further underwent a coronary angiogram, which confirmed the severe stenosis and underwent placement with a stent. So the expected result, increasing non-calcified plaque with increasing coronary artery calcium score. Candidates for coronary artery calcium who benefit from knowing their coronary artery calcium score is 0. Those that are reluctant to initiate statins, so they can understand the risk-benefit more precisely. If there's a need to restart statin therapy after discontinuation for statin-associated symptoms. So if they've discontinued the statin because they had some mild cramps, you do a calcium score, it's 0, then it's okay not to restart, versus if it's significant, you want to try with another statin. Older patients, so men whose age is more than 55 to 80 years of age, women who are 60 to 80 years of age with low burden of risk factors who question whether they would benefit from a statin therapy. Middle-aged adults, so men between 40 to 55, women 50 to 60 with borderline calculated 10-year risk of 5% to 7.5% with factors that increase their ASCVD risk. So take-home message, coronary artery calcium testing, it's a decision aid and not just a screening test. So calcium score of 0, you can defer statins up to 10 years. Exceptions are severe family history of premature CAD, ASCVD, patients with diabetes, severe hypercholesterolemia, and active tobacco use. You don't want to apply the calcium score of 0 rule to them. Patients with a coronary artery calcium score of 1 to 99, it's a risk discussion to review options for the patient, so look for risk-enhancing factors which may favor moderate intensity statin. Calcium score of 100 to 299 confirms the intermediate risk, so you want to give them a moderate intensity statin therapy. And calcium score of 300 or greater confirms higher risk. So you do want them to be on a high intensity statin therapy. Thank you.
I'm going to speak on, it's a basic talk to educate everyone that which patient of yours you should consider for transcatheter aortic valve replacement. These are my disclosures. So TAVR has been a disruptive technology. It began from the era when TAVI was proven to be superior than medical therapy. Then we went to TAVI being non-inferior to SAVR. Then we went to proving it to be TAVI being similar to via transfemoral access to SAVR in the intermediate risk. And from there, we went over to the low risk population, where we proved that transfemoral TAVR was either non-inferior or superior to surgical aortic valve replacement. There have been multiple trials published on this in NEJM for the low risk, intermediate, high, and the extreme risk for valves, mainly the Edwards Life Science valve and the Medtronic Evolute core valve. So these are the guidelines which basically drive our decisions in deciding which way the patient should go for aortic valve replacement. So when you look at the upper bar, which is the European guidelines, so they have a solid cutoff of 75. So anybody below the age of 75, surgery gets first dibs, and above 75, they are preferred to get TAVR first, depending on if the anatomy is right. When you come to United States, there is a minor difference. The age cutoff is 65. So below the age of 65, surgery is recommended. between the age of 65 to 80. It's an individualized and shared decision, and a lot of factors go into play, which we'll talk in detail afterwards. And about the age of 80, we believe that there is no role in surgical aortic valve replacement, and if everything goes right, TAVR is recommended as a first-line therapy in these individuals. So when you talk about United States, there are gazillion centers that offer TAVR. On an average, 77,000 plus TAVR procedures are performed. Compared to that, how do we fare in India? So India is an upcoming place where this technology is being absorbed and cultivated. There are approximately 180 plus centers of TAVR in India, and at least 4 to 5 centers at least that I know of in Ahmedabad. Volumes are currently concentrated in the major metropolitan cities, but it is expanding. CIMS Hospital here has been one of the pioneers in this field in Ahmedabad. So if you look at the Indian terrain, these are the estimated cases. I do not have the exact number, but there was an estimate of around 2,000 cases to be done in India. India is different. The amount of bicuspid aortic valves in India are way higher compared to United States or Europe. So in the population that I treat in United States, it's 10% of bicuspid valve. In India, it's 40%. So it's a completely different anatomy that India deals with. There has been a lot of data that has been shown that at least 40%, if not more, patients with severe aortic stenosis are not treated with any form of aortic valve replacement. It's a highly undertreated population, in spite of us knowing that the clinical implications are very high. Probably the reason for the treatment gap is, as age goes by, we feel that any form of intervention is risky. Either the referring physician deems that the patient is not the right candidate. Like in India, we see that there could potentially be at least 2 million patients with aortic stenosis, but roughly around 20,000 people are treated or offered treatment. Whether they decline it, that's a different conversation altogether. We all know that almost close to 90% mortality in 5 years if the patient is untreated. This is just a prognostic chart showing that how does symptomatic aortic stenosis fare with other metastatic cancers. And if you see that the prognosis of survival for severe inoperable AS is way higher compared to lung cancer, colorectal cancer, breast cancer. So this is just a slide to show you the importance of what severe AS can do. And sometimes sudden cardiac death can be the presenting feature of this disease. So a lot of things needs to be done in developing countries, especially India, with uptake of this therapy. One of the things that I feel what is holding us is there is no referral path. Reimbursement, of course, is a big issue, and affordability as well. And obviously, low awareness amongst patients as well as physicians that this is a potential therapy option. So we talked about heart team, individual shared decisions. The heart team decision has evolved substantially over the last 10 years in deciding alternatives between surgical and transcatheter valve replacements. So initially when we started the heart team for extreme high and intermediate risk, our focus was what could we do to reduce mortality, stroke compared to surgery or vice versa. How do we improve quality of life? And we knew that pacemaker is a part and parcel of this therapy, be it surgical or transcatheter, but we would choose one that would be favorable for the patient. But now as we turn around towards lower risk and younger patients, a lot of other factors need to be considered by the heart team. Hemodynamics of the valve, patient processes mismatch, because these patients are much more active, so we don't want to leave them with higher resting gradients. We also want to look at durability and life expectancy. Like, think about yourself. If you're getting a surgery done, You don't want to come in again for a reintervention. So we want to minimize that as well. And that is also an important thing we take into consideration. In younger patients, you also have to look for coronary access. If you put like a stage, like a stent valve in front of the coronaries, then sometimes the access to that is compromised as well. So all these things need to be taken into consideration. So this is what I feel like, in a heart team discussion, there are multiple features, but it all boils down to three major key factors. One is, what is the age of the patient, and what outcome do you want for that patient? What do you think is the valve durability? How long will that valve last, and how much reintervention would that patient need? And the third is the anatomy, like whether can I do this safely, get in and out without any complications. And on the basis of these three major factors, the cardiologist or the surgeon would decide which one is favorable, a surgical approach or a transcatheter approach. So let's talk about life expectancy. Like in the United States, the average age is 87. So that's why we came up with a cutoff of 65, that you get one valve at 65, be it surgical or let's say a TAVR, then probably in another 10, 15 years, you get one reintervention, and that should be good enough to take you past that average age. In India, from what you see from the data, the average expectancy is 67. Correct me, I could possibly be wrong. So I do not know what the cutoff for India should be. Should it be 60? Should it be 55 for your first intervention? But that is up for a debate. I feel it should be 60. And on the basis of that, that should get you 10 years and probably another reintervention at the age of 70 or 75. But our goal is to keep reintervention times one only. So some of the anatomical considerations that you want to do is bicuspid aortic valve, very aggressive pathology, very aggressive calcification. If you have a concomitant aortic dilatation, concomitant valvular disease, extreme CAD, where a surgical approach may be much more beneficial. Infective endocarditis, rheumatic heart disease are some of the other subpathologies. Sometimes your access may not be favorable when it comes to femoral access, or the degree of calcification is so significant, as seen in the picture on the right, that you may not get an adequate seal with a transcatheter valve, and the risk for annular rupture, pacemaker, paravalvular leak is so high, where surgery makes more sense compared to a TAVR. Regarding the durability of a transcatheter valve compared to surgery, there has been tons of data published. I'm just showing you one of the NOTION trial, which has one of the longest follow-up. Not a huge trial, but when you look at the numbers of the mean aortic valve gradients and follow them up over a prolonged period of time, the structural valve deterioration rates are much less with TAVI valves compared to surgical aortic valve replacement. So as a patient, when you have a patient in front of you, so what are the things that goes on in a patient's mind when they are deciding what is the best treatment for them? So the first thing is trust. Like, they need to trust the therapy, whether it be surgical or transcatheter approach. And that's where the physician taking care of the patient, they come in handy, because if you trust the therapy, then your patient will trust that therapy. Information about options. If the patient has no information about surgery or does not have any information about a transcatheter approach, they will not be able to make an informed decision. Everybody wants to live a long life, right? Like, if they come to you for any form of therapy, the first thing they say is, lambu jeevu cha, right? So that is something that you have to take into consideration. You have to reduce the fear of heart failure. If AS goes undertreated, rehospitalization for heart failure, it goes without saying, it is going to happen. You have to consider improvement of the quality of life, which will be a difference in TAVR versus SAVR, and that needs to be taken into account. You have to feel comfortable about the decision that you make, and that all depends on the trust that you have on your heart team that you're referring the patient to. And this is a very debatable point that I'm going to make, that apart from the patient's criteria and need, you have to take the heart team's experience into account. And I'm going to say it as it is, like, not all interventionalists are expert TAVR operators, and not all surgeons are expert surgical valve operators. So that needs to be taken into account before you make that decision for your patient. My key takeaways from this talk is severe aortic valve stenosis patients are largely undertreated, and they have a high mortality.
The insight is that TAVR is a definitive therapy and it's not a palliative treatment. So patients who are worried about surgery, open heart sternotomy, and they have good valvular anatomy, this may be a very definitive therapy which will last them long and will have very good outcomes. Severe AS patients, as I said, demonstrate significant benefits from TAVR. And in my opinion, for Indian population, there is no data to support it or any guidelines. But I feel that anybody above the age of 60 who has severe aortic valve stenosis of any kind should be considered for a TAVR. Whether they get it or not, it all depends on what their anatomy looks like. So age more than 60, you should get a coronary or a cardiac CTA. And on the basis of that, the heart team should decide what is the best approach for that patient. Thank you very much.
What I'm going to talk is probably going to be very useful in your day-to-day practice. And what I've included is some of the clinical case scenario which you come across in your day-to-day practice. And the molecules are already available at Ahmedabad. Okay, so that is the reason I have kept all these molecules. Now this is the first case, the female 47, she is obese, she has asthma, she is having severe obstructive sleep apnea. Her blood pressure is high, 150 by 98, weight is 95, and BMI is 36. HbA1c is on the higher side, 6.8, LDL is 150, LFT is normal, 24 hours blood pressure confirms hypertension. A patient has started the diabetic prevention program and the weight was reduced about 3 kg. Blood pressure also is slightly better with ACE inhibitor and HbA1c has gone down. Sleep apnea basically continued. What are the options for this patient? Can we have a voting put? Continue the lifestyle intervention, start the oral anti-obesity medicine like orlistat, something else, live with this is the genetic disease, take care of hypertension, diabetes, or consider a bariatric surgery. So, probably I think I should be talking regarding this really much. Now let us understand the problem. Obesity, overweight, otherwise also is associated with higher cardiopulmonary disease, cardiovascular disease, and heart failure. Not only cardiac, but other things like knee problem or fatty liver, lung problem, everything is high with obesity. Obesity is basically classified into 30 to 35 is mild, class 1, class 2 is 35 to 40, and more than 40 is obese. Morbid obesity is defined as more than 40 or 35 to 40 with a significant comorbid conditions. What we have to understand, if you reduce the weight by about say 5%, the blood pressure will be nicely controlled, diabetes will be controlled. But if you really want to revert the what we can NASH or sleep apnea or knee problem, then significant weight reduction should be achieved. And if you want to reduce the cardiovascular mortality or diabetic remission, then it's in the range of more than 15%. So what should be the target in this? Definitely it's going to be, because the patient is having sleep apnea, it should be more than 10 to 15% according to this. Now, which are the molecule which is available? GLP is a good new thing which has come up, GLP analog. Basically, there is a relation between gut and the brain. It reduces it is licensed for weight reduction. These are the two molecules which are probably available at present. And in different subset of patient, like patient having pre-diabetic, diabetic, or sleep apnea, significant weight reduction was achieved. And if you look at the percentage of reduction weight with this molecule, it is in the range of almost 15%. So significant weight reduction can be achieved. So it also reduces the blood pressure, systolic, diastolic, CRP also can be reduced significantly, and it is very well tolerated, may have some GI side effects, but otherwise it is very well tolerated. So these are the approved drugs, some of those are available. Orlistat is the drug which is available at present in India, but it reduces the weight by about 5% and significant side effects are there. Two new molecules, liraglutide and semaglutide are the new molecule which is a GNP-1 analog which can significantly reduce the weight. So definitely now we can answer. Can I have a voting pits? So semaglutide is the option. So definitely this is the option which was started in this patient. 3 milligram oral tablet started, increased to 7 milligram and then 14 milligram. Significant weight loss. Now the weight is 82, BMI has gone down. HbA1c is very well controlled. Blood pressure and breathing problem also is significantly improved. Another molecule which is going to be available, which is approved in Western, but not at present. And what they have done is obesity without diabetes. And here also you can see almost 15 to 20% of weight reduction can be achieved with this molecule. So definitely, as Kyorby also has mentioned in his talk, pharmacotherapy is going to be the good way in managing obesity. Under real life case scenario, the patient is having coronary disease, 99% disease in LAD. Angiography was done outside. Patient also had a piles problem. Piles problem was not relieved, but because the significant coronary blockage, the angioplasty was basically suggested. And the patient has undergone the angioplasty. Patient was on ticagrelor, and patient now had a severe piles problem and needs an urgent surgery. I told them that there is something like a new molecule which is available. We have to bridge in your patient, but patient did not agree. Ticagrelor was stopped for 3 days, and after stopping 4 doses of ticagrelor, patient developed an acute MI. An emergency angioplasty has to be done. Of course, the patient survived, but the ejection fraction now is 40%. So this is the clinical scenario which can be very, very, very detrimental. That is one thing. Second is another patient is infeval MI, severe triple vessel disease, bypass was done. Patient had acute cholecystitis and impeding perforation. Patient was on dual antiplatelet agent. Now what to do? Whether to stop the both antiplatelet agent or just do something else. Now this is the molecule which is cangrelor, which is available at present. It is a very effective molecule. Rapid and reversible platelet inhibitions can be achieved, and it extensively inhibits the platelets within 2 minutes of IV infusion, and it can withdraw, once you withdraw, the effect will stop after 60 to 90 minutes. So it's a very, very good molecule, and which is especially using in this kind of situation where the patient is having high thrombotic risk, at the same time patient is having high bleeding risk, and patient needs a non-cardiac surgery urgently, and we cannot postpone the surgery, where you have to bridge. And this is the standard way of bridging. As you can see, the one antiplatelet, the aspirin should be continued. Prasugrel, crucurgrel has to be stopped before 3 or 5 days, and we have to, after 72 hours, we have to start the IV infusion, and we have to continue till the surgery. Once the surgery is done, and after that we can resume the antiplatelet agent, second antiplatelet agent. It is basically safe, no bleeding will be there during the surgery, and cardiovascular complication also will be very good. Another scenario, young patient, 40-year-old, had a cardiac arrest in the emergency room. Patient was intubated. Patient was loaded with antiplatelet agent, but patient is meanwhile vomited also. We don't know how much antiplatelet efficacy will be there. Angiography showed there is 100% occlusion. Whether to rely on the antiplatelet agent or not. Here also there is a role of cangrelor, because some of the patient, maybe 10-15%, may have vomiting or a cardiogenic shock where oral antiplatelet agents cannot be given. IV cangrelor is going to be the molecule of choice in this group of patients. Another thing is, suppose this is another patient is having ejection fraction of 30%, creatinine is basically normal, potassium also is in the normal. Patient is on carvedilol 25 milligram 2 times a day, Lasix. Arni is 200 milligram 2 times a day. Spironolactone also is patient is taking. Aspirin, atorvastatin, dapagliflozin, and metformin patient is taking for his all medical conditions. Now this patient suppose has a worsening of heart failure, meaning by patient requires an IV diuretic or heart failure admission or urgent admission in the emergency room with heart failure symptom. Now these are the group of patients where we can definitely define them as a worsening of heart failure. Sometimes you may have a standard medicine, but patient is not tolerating because Arni, suppose there is severe hypertension and patient cannot tolerate this medicine. These are all the group of medicine where something more needs to be done. So what are the medical options? As we can see here, all the 4 groups of agents are in the highest dose. Still the patient had a worsening of symptoms. So that is where the role comes of vericiguat. Vericiguat is an important molecule. It ends on the different pathway. This is the study, Victorian study, which clearly shown dose is 2.5 milligram to start with and gradually increase to about 10 milligram. This is basically a direct stimulant of STG. It is also increasing the improving the endothelial dysfunction, and is beneficial as far as heart is concerned. And if you look at in this subgroup of patient, it reduces the mortality by almost 10%. So this is a very, very important or a very useful molecule. And it can be given in all subset of patients, creatinine up to 30, eGFR of up to 30. This molecule is definitely going to be useful. So it doesn't cause symptomatic hypertension, which is many times a problem with the Arni. So we can use this molecule very safely. No major side effect as far as renal function is concerned and electrolyte function is concerned. So it is a very, very, very good molecule in this kind of situation. So this patient is already on 4 pillars of heart failure. Vericiguat also was started 2.5 milligram one time, and it is increased every 10 days to 5 milligram. The creatinine also was normal. Hypertension was not seen, and the patient may have prevention of heart failure recurrent admission. This is another patient where Arni is not tolerated, okay, because of hypertension. We know that these are going to be a bad patient because patient is not tolerating a standard guideline directed therapy. So definitely something should be done. So what are the options for when verisucate should be used? It is for heart failure with reduced ejection fraction, especially when there is a worsening of heart failure, that is one in spite of all guideline directed medical therapy. At the same time, if the patient is unable to tolerate the standard medicine, verisucate is a very good option. Now coming to the another subset of patient like pulmonary hypertension, as you can see, this is a patient who is a 40-year female, Reynolds phenomena, severe systemic hypertension is there, rheumatologists have diagnosed systemic sclerosis, and patient was taking care of this. Patient had a progressive breathlessness and now come up with a right-sided failure or a pulmonary hypertension. And the echo was done, clearly showed that there is a severe pulmonary hypertension, systolic of 75 and mean of 48. Now this is the pH which is developed in a connective tissue disorder patient. Another patient, 36-year-old female, patient has increasing breathlessness, no other medical problem, lung, everything is normal, and patient had a severe pulmonary hypertension, PS systolic pressure was 80, NT-proBNP which was measured was 800, and 6-week walk distance was only 350 meters. Now these are the molecules which are available, okay, as far as pulmonary hypertension, idiopathic pulmonary hypertension comes. Endothelin receptor antagonist, endothelin pathway which is acting is macitentan. Verisucate is the another molecule which is acting on the nitrous oxide pathway, and selexipag is basically acting on the prostaglandin pathway. Now whenever a pulmonary hypertension patient comes, okay, when it is not because of left-sided or a lung pathology, first and foremost thing we have to do is to risk stratify. Okay, there are certain ways of risk stratifying, and BNP, 6 weeks walk distance are an important thing which can risk stratify this group of patient. And what we have to keep in mind that if the patient is either intermediate or a high risk, there is going to be something like a combination therapy to be started since beginning, acting on the three different pathways. So as we will discuss, the first patient of systemic sclerosis, it also falls into high risk, and this patient was, we know that if in a high risk patient we start a triple drug combination, that is much better compared to a dual drug combination. So that is a message which should be, so high risk pulmonary hypertension patient. So this patient was started on macitentan, tadalafil, and selexipag simultaneously and gradually increased. The NT-proBNP has also come down, and now the patient is in the low risk group according to the risk stratification. That is what the purpose when we start a treatment for pulmonary hypertension. Suppose the patient is started with the dual therapy, the important thing is we have to follow this patient 3 or 6 months and try to bring it to the lower risk patient. If still the patient is either intermediate or high risk, something needs to be done, because we know that triple drug combination is definitely better. So this is the another patient which I have described. NT-proBNP is high, patient is falling into intermediate risk group, and initially we have started the bosentan and ambrisentan, and after 3 months, patient is still in the high risk group, and that is the reason we really need to add something else. And selexipag is an important molecule which is a prostacyclin analog molecule, and which can be given orally, not a subcutaneously, and as you can see, 40% reduction in major outcome which has been achieved with this molecule. So selexipag is an important prostaglandin receptor agonist which can be given for idiopathic class 1 hypertension, not other group 1 hypertension, idiopathic or associated with connective tissue disorder or congenital disease where there is a repaired shunt and still pulmonary hypertension is there, and patient is in function class 2 and 3. So this also is an important thing. Another time, sometimes you may come across a patient who is having severe pulmonary hypertension, severe pulmonary massive embolism, and you have treated the patient. This is the patient where thrombolysis was done, but patient presented little late. Thrombolysis was done, but still at the end of discharge, the patient had pulmonary hypertension and RARB was significantly elevated. So patient was discharged on rivaroxaban 15 milligram at that time. Patient had a persistent pulmonary hypertension residual post-thromboembolic episode after 3 months. If you look at the systolic blood pressure, it is definitely high. And if you look at the NT-proBNP, also it is high. And walk distance is intermediate, that is 390 meters. The one option for this group of patients is endarterectomy. That is a surgical endarterectomy which can be done. Now, which are the options for this group? Can we have a voting pad? So, surgery is the option, but what I wanted to share is there are so many newer options which are available. If there is a patient who is having residual pulmonary hypertension after thromboembolic episode after 3 months, then and it is non-operable many a times, or patient is not accepting the surgery because it is little complex and high-risk surgery. These are the molecules which can be used. So riociguat is one molecule which is approved for this subset of patient, and macitentan also is approved for this group of patient. So this patient was basically started on macitentan. His PA pressure after 3 months has fallen to 36. RARB is now normal, and patient is continued on rivaroxaban. So those patients, thromboembolic, residual pulmonary hypertension, these are the molecules which can be given. Now 2-3 last questions. How much weight loss is expected when you start GLP-1 receptor agonist? Basically, it is going to be 15% weight loss can be achieved with this whole GLP-1 analog. Next. So basically, it's going to be more than 15%. If you don't achieve, then the benefit is definitely not going to be there. Last one question. Which is the best strategy with undeferred surgery, 1 to 3 month post-angioplasty, high thrombotic patient? So definitely answer is going to be D. Cangrelor is to be started in this group patient. And last one. What is the offset and onset of cangrelor? So it's 2 minutes and 60 minutes. Thank you very much.
Ways of cardiologists to succeed with marketing.
So I have no financial disclosure related to this lecture. So marketing tips for cardiologists and physicians in general is to use for practice building and patient loyalty. Number one, you need to know your cardiology target population, and you need to use local search marketing for your cardiology practice. And there's something called master search engine optimization. And connect with your cardiology patients on social media, consider digital advertising, leverage email marketing, and create consistent online content for your patients, and attract patients with video medical marketing, and track your performance periodically, and employ marketing experts. That's very critical, and expand your service line for other things other than cardiology. So number one, note, how do you know your cardiology patient target population? It's challenging, but it's not impossible. You come up with effective marketing tactics if you don't clearly understand your audience, and create your own personal persona that represents your typical patient. And always think about your age group of patients, the heart conditions, the diseases you would like to treat, socio-economic class, and social media habits and behaviors of local patient population. Once you identify your typical patient, you build a marketing plan that addresses their needs, and show empathy about their challenges. And use local search marketing for your cardiology practice. When patients want to find a practice or get more information, they always usually turn to Google, and your search engines are powerful, helping patients to find more information about your practice. And local search in particular is critical for cardiology office locations, so you need to understand where locations are. And master search engine optimization, periodically have somebody to keep looking at this. Yeah, use local search marketing for your cardiology practice. Set up a Google My Business profile, so your office comes right up when someone searches for a local cardiologist. And most times, listing will already be done by Google, but you have to just go and claim it and make sure the information is accurate. And patient reviews are very critical. That's establish trust and authority. And ask patients to review your business on Google My Business, and third-party listings help stand out compared to other cardiologists. And connect with your cardiology patients on social media. Social media is a perfect place where you can connect with patients, and all are for free. Potential patients can get to see what interacting with your office and what's the type of patients so that you can keep on your mind. It's not necessary that you need to be on every social media platform, but use whatever you use it consistently and efficiently. There are advantages for each one of them, but just target to each patient population. And always connect with your cardiology patients on social media by what? By Facebook, Instagram, TikTok, or Twitter. Again, depends on what's more popular. Again, Facebook is most popular among all of them, but everybody are familiar with each platform. And large hospital systems have their own channels to market also, and that you need to capitalize on that. And consider digital advertising. Patients have more choices than ever to choose a cardiologist practice, and more likely, and which is visible option to them. Digital advertising is one way to ensure that your cardiology practice targets the right market. Optimize your website by mobile usage. Everybody uses a mobile phone, trying to make sure that you pop up on a mobile phone, it's user-friendly, and then you keep in track of that and make sure it is up to date. And timing is always everything. And consider digital advertising. A few ways patients are targeted is by retargeting. Potential patients who looked at your page is critical. So look at who is looking at your page and just go back and make sure you target them, see what's in their mind, and use Google AdWords. So the pay-per-click, the Google Ads will help you search for people. On social media platforms like Facebook is also, as we talked, is very useful. You'll increase your chances of landing a new patient when you target ads in a specific audiences. Again, timing is everything. Generate new patient reviews by increasing your reputation, because if you have a good reputation, you get more patients. Likely you need good online reviews, and always when you pick a new doctor, they're looking for your reviews. Whoever has a review closer to 5 is probably a better person suited to get new patients. And there are many places for online reviews, WebMD, Google, and other websites. Keys to connect these sites and generate data to help your practice. And they're more likely to earn your trust, more likely to earn your business. And leverage email and marketing and consistent online content. Send free health tips and health-related news stories and newsletter to patients. It helps check up patients to create awareness of your services and establish practice generally concerned to patients' health. Cardiology marketing works best when you regularly create and post consistently relevant online content. And some topics you address include speaking to some of these common cardiology challenges and patients' face of providing advice to patients to live a healthier and fulfilled life. It can be difficult to come up with the topics and relevant content, but setting and maintaining a regular schedule and help them be top of your mind. Think ahead what you want to talk and then stick to your schedule. And attract patients with video medical marketing, one of the most effective tools to promote a practice. And getting your physicians to create a video content can help improve reputation management. And visual content engages more senses and therefore is better comprehended and retained by potential patients. Always post a video on YouTube, which is very most commonly used, so that people can understand. Obviously, you can have Facebook Live and other ways you can improve communication. And set your goals. After reviewing your business performance, industry landscape, it's time to set up your goals. Increase your brand awareness. It's always creating your own brand. Manage your reputation. Increase lead generation. Grow social media clout. And increase website traffic. And do not limit yourself to just these recommendations. Always looking for something called a SMART principle, where it can be specific, measurable, achievable, realistic, and timely. And always focus and set a goal for success. And know your audience. It's very important to understand who is your audience and what's your social economic status, what their age group, what conditions you're targeting locally, and behavioral patterns. And this is important to understand how the practice will work. Track your performance and employ marketing experts. Emphasizing marketing experts are very, very critical in growing your practice. A marketing plan is important, which is based on solid research and goals are known. And ensure using relevant, accurate data when drafting a plan, and track the data so that you know whether or not your plan is doing well. And you can always use Google Data Studio or CRM to track your potential patients, and use the numbers and tweak and improve your marketing campaigns. And track your performance and employ marketing experts by looking at mastering cardiology marketing practices. These professionals can only save your time and find the effective ways to build practice. And just like healthcare experts, these experts are very useful in marketing your practice. You just take care of patients, let the marketing experts take care of marketing. And expand service line. This is something which I learned personally from general cardiology to include other practices, which could be structural heart, it could be vein practice, it could be peripheral arterial disease practice. So you can expand your service line with respect to testing in your office. You can have an office-based lab, an hospital-based setting, and so you can just basically expand from a general cardiologist to be a comprehensive cardiovascular specialist. And to craft the perfect cardiology practice marketing plan, you need to understand, as again Dr. Kurt Lee talks about, there's always going to be something that's either disrupts the market or intervenes in your best laid plans. With that being said, good marketers are prepared, and they're creative people, and they're analytical, and then they use different ways to establish and market yourself. And always reach out to marketing experts to help you grow your business. Take-home points. Marketing for cardiologists have become more complicated over the past decade. Retained, experienced employees is important, and you create a blog that can improve the reputation of the cardiology practice, evaluate detailed feedback and studying the benefits of branding, and finding the right tactics and proven marketing strategies to make that impression will empower practice to reach new patients, engage current ones, and achieve goals of the practice, and will keep practice thriving for the years to come. And execute proven marketing strategies and tips for yourself, which sets apart from the other cardiologists, and have a competitive practice, and start attracting new patients, but keep retaining the old patients. And some tips are easy to employ, and you and your office staff can do that easily. And having a good office staff is very, very critical for a good cardiology practice. However, just like you are an expert in healthcare field, always employ marketing professionals who can help you grow your practice, and consistently follow what is up there. And always go on your online and understand what is written on you, what kind of reviews you have, so that you continue to grow and develop yourself. Trust them to know that how to most effectively use the above techniques and best results for your practice. Improve the reputation of a medical practice and study the benefits of branding. So healthcare branding is so essential. So if you work for an institution helps you, but sometimes you have to do it on your own and try to continue to grow and get better. And always listen to feedback of patients, because patients are always right. Thank you for your attention.
These are my disclosures. I'm going to start with a simple case. 58-year-old woman presents with NSTEMI. Straightforward. Like last few cases, we were worried about stenting and not. 58-year-old, everybody agrees they're going to go for stenting majority of the times, if it's an NSTEMI and if the lesion is right. With hypertension, preserved LV dysfunction. The angiogram shows severe LAD diagnosed stenosis. So if you see RCA does not have any significant stenosis. The proximal LAD right by the first diagonal and the septum, the proximal LAD has a bifurcation stenosis, Medina 111. So I was working with a fellow, and he asked me, should we use an IVUS or an OCT to decide? And me being the attending at that time, I asked him, what for? We get great results with angiography. So what do we know? Twintex is a 5-year-old follow-up data trial, which has data from the Resolute registry, from the Science V arm as well. And if you look at the 7th row here, which looks at target vessel failure. So at 5 years, the failure rate for a revascularization or need for one was 15 to 18%. So the main question is, yes, angiographically results are good, but can we be better? So the fellow kept on insisting, maybe we should image. And I said, there's really no data. Actually, that's not true. So intravascular imaging improves PCI outcomes. And it has shown that by using intravascular imaging, you can cut the stent failure in half. And that has a lot of implications. If you cut the stent failure in half, meaning it directly affects mortality, it directly affects MI, it directly affects cardiomyopathy. It has great clinical implications. And to support that, these are some other data that has also have shown positive results on the use of intravascular imaging. So there is abundant data to support this strategy. The attending still doesn't want to do imaging, feels that the hospital administrators will be on his case and like, why are you using it? There has been cost effectiveness data done for IVUS especially. And as I had mentioned that because you cut the stent failure rate into half, not just at an individual level, but also at a heart healthcare system perspective, you are reducing your overall healthcare costing. You almost reduce it by 20%. And if you do it in the right way, you get more efficient in bulk buying, that cost even goes down further. And the reason why I show this slide is there is always a misconception amongst cardiologists, interventional cardiologists, physicians. They say that, this is just used as a tool to get more money. But that's not the case. This is not just about money. Yes, there is an additional cost to it, but there is a way greater benefit out of it. Like for all those physicians here, you refer your patients to Dr. Kiyur Parikh, Dr. Anish Chandarana, right? So what do you ask them for it? Like, you're sending a patient for a PCI, but you should ask them what do they do. You send them because they are high risk operators, heavy volume operators, right? But you have to ask them, do you do imaging or not? Because if their loved ones are going for a PCI, they are going to ask for imaging. So you should ask for your patients as well to have them do imaging in their cases. So when you do image-guided PCI, the three things that you look for is obviously the pre-intervention assessment, where you look at what the morphology looks like. Dr. Tejas Patel in the prior talk very categorically mentioned like the characteristic of the thrombus and the plaque erosion. After that is addressed, then you can devise a plan for yourself. Then you look at like how the stent, what stent to choose, how it is deployed, how does it look, and if there is any other additional complication post-stent deployment. Imaging will help you for all. This is just an example, like, why imaging is important. These both are left main lesions, and you will see a discrepancy. Like if you look at the angio on the left main appears to be okay. But when you do an IVUS, the left main area is 4.6, which is physiologically very significant. On the right hand side, you look at that left main bend right up on top, which is depicted by the arrow. You see that's a tight stenosis. But if you do an IVUS, that area turns out to be 8.6. This is not significant. Like, an angiogram is a 2D depiction. So it's like this. So it's like a pancake. If you see from different views, you will see whether it's thin, and if you look like this, it's thick. So that's where IVUS or any form of intravascular imaging comes into play. So let's look at this cartoon. It helps you to get a basic idea of exactly what do we do with intravascular imaging. So first of all, we look at the morphology. And if you look at this cartoon, basically you're looking at, there's a tight stenosis, and there is circumferential calcium. You can also get a rough estimate on the length of the lesion. Like, you can see that, this is a normal landing zone. This is the normal landing zone. Roughly, it's around 10-15 millimeters, so you can choose your appropriate stent length. After the stent is deployed, you can evaluate the stent edge to see if you tore up this edge of the vessel. You can also see if the stent is well expanded, getting appropriate vessel areas, if it is malapposed or not, which I'll show you what it means, and etc. So one of the lesion characteristics for you to know is the images, the first image is of a normal vessel. Then you see this is the most common form of atherosclerosis, which is like a soft plaque, which you commonly see in younger patients. As the atherosclerosis matures, they get more fibrotic because it will be seen as a much more denser plaque on IVUS, and then they calcify over time. And that's how they are depicted. So the basis on how we see these lesions, we decide whether the patient needs a rotational atherectomy or just a simple plain balloon angioplasty should suffice. So this is an example, like angiographically the stent may look great, but on an IVUS you will see that a stent is just floating. When you have mechanical results like this, then you can't even blame the patient for stopping Plavix for one day. Your chances for a stent failure will be very, very high for stent malapposition, one of the most common mechanical reason for stent thrombosis. These are just other examples of extensive tissue protrusion, malapposition, and the first one is of an edge dissection. So our patient, we did an IVUS guided 2-stent technique with great results, with great angiographic apposition with an area of more than 5.5. In conclusion of my talk, there are two simple points that I want to bring to the audience today, that by using intravascular imaging, you become more efficient. You develop a better understanding and recognition of how you treat your patients and how your disease responds to the intervention. And you can also be confident that you're providing consistent care and long-term outcomes So one of the analogy I always tell my fellows is if you play cards or if you like playing cards, angiography is more or less like playing blind. While using IVIS, you have all the information in front of you, so you can make a better decision for your patient with a better long-term outcome. Thank you very much.
I will share a couple of interesting cases of acute coronary syndrome in the young population, young patients. So let's start with number one case. Male patient, 29 years old, smoker, presented with trop positive non-ST elevation MI. ECG is showing a valence kind of pattern. He had one episode of rest angina 24 hours back. Echo was almost normal with mild hypokinesia of the LAD territory. And this is the angiography. RCA and circumflex is normal. And this is the LAD picture, what you see on the screen. You can see that there is a proximal LAD here. There is a lesion with huge thrombus there. You can see it in the other images also. It's not only a simple lesion. There is a huge thrombus also along with that lesion. So what should be the treatment plan for this patient? Should we go for the direct stenting, thrombosuction followed by stenting, thrombosuction without stenting, just leave it after thrombosuction, or give intracoronary thrombolysis? Okay, so majority of are agree with the thrombosuction followed by stenting. It's a good answer, and I would like to discuss at the end of all the things. So I did OCT because patient was absolutely stable. The flow, if you see in the angiography, was TIMI3 flow. It was perfectly good flow. And this is the OCT image. We all know that OCT is the optimal coherence tomography that takes imaging from the coronary artery from inside. And we can see the pathophysiology or the problem which has created the acute coronary syndrome in this patient. You can see this is a huge thrombus, red thrombus there, and which has given the luminal narrowing. And if you see the actual area stenosis, which is hardly 58%. So the actual problem was the thrombus in the underlying lesion. Because of the thrombus, the lesion was not visible, underlying lesion was not visible clearly, but the area of stenosis was only 58%. Another case, 24 years, is a very, very young patient, obese smoker, again same presentation, troponin positive, NST elevation MI, EF is normal, chest pain 2 days back, and if you see it here, again the similar picture in the LAD, RC and circumflex is normal. Even in this patient you can see the LAD lesion is very minimal, but there is a huge thrombus lying there. The thrombus is almost moving there, the white thing is thrombus there. And the flow distal to the lesion is excellent. It's almost normal, TIMI3 flow. Again, the OCT of this patient shows similar picture, almost similar kind of picture. Area of stenosis here is hardly 35%. And the distal vessel is completely clean. This is the distal vessel. Here is the lesion with the thrombus. So you can see this is a thrombus here. And you can see there is some plaque rupture also in some of the images we can see. Again, this is a thrombus, but there was no complete occlusion. The underlying lesion shows, here is the plaque rupture, you see, here is the plaque rupture, it was there. So again, the area stenosis was very less. The third case, 39 years old male, again, almost similar picture. And this is the angiography. You can see it here in the proximal LAD, the thrombus and the minimal lesion. And OCT is showing again a very good picture with the plaque rupture, and the area stenosis was hardly 60%. This is a thrombus, and there is underlying lesion there. So what is similar in all these three patients? Young patients all having multiple risk factors, metabolic syndrome, non-ST elevation MI, trop positive, clinically completely stable, pain-free, angiographically good flow in the culprit artery, TIMI3 flow at least we need to achieve in the STEMI situation. They have that at the starting of the angiography. OCT was showing thrombotic lesion with the either plaque rupture or plaque erosion. And underlying lesion was not that much, it is hardly 40, 50 or up to 60% in all these three patients. So we have a good trial which is addressing this kind of situations. Still, we don't have the proper guideline for this kind of situations. But the Erosion 3 trial, which was presented last year in the TCT, what they did was in the STEMI patients, after angiography plus or minus thrombus aspiration, when they achieve TIMI-3 flow and the diameter stenosis is less than 70%, they randomize into OCT guidance angioplasty versus angio guidance angioplasty. So if OCT guidance, if they show that the plaque, there is a plaque erosion, there is a spontaneous coronary artery dissection or spasm or rupture without dissection, they deferred stenting in those patients and put on the antiplatelets and the medical therapy. And angiographic guidance, when they feel that standard of the care, they advise for the angioplasty and the stenting subsequently. And they did the follow-up up to 1 month and the 1 year. And the objective was that to test whether OCT guidance in compared with the angiographic guidance only is associated with lower stent rate in the STEMI patients with non-obstructive stenosis when the area stenosis is less than 70%. And they found that the rate of stent implantation in the OCT guided group was 43.8% in comparison to the 58.8% in the other group. And they have achieved that the lower stent implantation in those patients with full safety endpoints. So what we need to see in the OCT is that whether the plaque rupture, this is a plaque rupture, you can see it here, the underlying plaque, and there is a breach of the intima which has exposed the underlying plaque, and this is the reason for, this is a pathology for the acute coronary syndrome, ACS or STEMI or NSTEMI. And this is a plaque erosion where there is no breach of the intima, but there is an irregular luminal surface and there will be overlying thrombus over that. So in the first case, what I did was thrombosuction followed by triple antiplatelet for some time, followed by double antiplatelet, LMWH, high dose statins. In the other two patients without thrombosuction, the patients are doing good. This is the first patient initial angiography, and this is a follow-up angiography after 2 months. And we can see that the thrombus is completely clear now, and there is an underlying plaque, underlying lesion, which is there, which requires only, which is very minimal and which requires only medical therapy. So the take-home message that the recent data shows that the medical therapy without stenting may be an option for treating plaque erosion, SCAD, spasm, which are difficult to diagnose by only angiography. OCT allows for accurate assessment of different underlying mechanisms of myocardial infarction in selected MI patients. Remember that when the patient is unstable, when we don't have TIMI-3 flow, when the patient is clinically unstable, having recurrent VT, having pain, we need to go for the angioplasty. Still, that is the best option to go for. But in selected patients, when the patient is stable, we don't find any high-risk features in the OCT. Without significant obstruction, OCT guidance can reduce the rate of stent implantation in those patients during primary PCI. Anyway, we need to do further larger trial for the assessment of the safety and cost effectiveness of this strategy. Thank you very much.
This is indeed humbling to be present here. This is my hometown. This is where the journey started. In many ways, I'm frankly glad that I moved to USA. Otherwise, I'd have to be competing against Anish all these years. He's done a brilliant thing with his career himself. So, I guess everybody's getting older. I'm getting older. The very fact that I've been asked to give a talk like this, to pontificate about the future, that's circle of life. But thank you again, Keurbai, Anish, and Milanbai, whom I've known for such a long time. Thank you again for this honor. It truly means a lot to me and my family. So, precision cardiovascular medicine, the next 15 years. I've been asked, I chose this topic not because it's an easy thing to talk about, but it's a very difficult thing to talk about. It is very hard to predict, especially the future. A famous baseball player said this very well. Yogi Berra said this. But believe me, the future is already here. It's just not evenly distributed yet. I strongly believe in the following. Once a new technology rolls over, If you are not part of this steamroller, you become part of the road. It is absolutely important to be ahead of the conversation. To be in the conversation, you should not be shunning technology. You should not be stopping to ask new questions. My favorite thing to say to the fellows and trainees is don't ask why, ask why not. I think that's the most important thing. Where have we come from? Where are we going? The past, how have we looked at the world of medicine and investigations? A lot of it has been intuition medicine, look at signs and symptoms and hope that you are right. The present is, you've seen a lot of evidence shown today, a lot of randomized trials, evidence-based medicine, guideline this, guideline that. But believe me, the future is not a broad stroke of brush, but a fine paintbrush with precision medicine, artificial intelligence-based algorithms, etc., how we are going to practice medicine in the next 10 or 15 years, or at least that's the belief, that's the hope. What is the potential in cardiovascular medicine? Every aspect of cardiovascular medicine, in my opinion, will be impacted by precision therapy and machine learning, artificial intelligence, no matter what, intervention, imaging, heart failure, genetics, you name it. This is something that I got out of Twitter, actually. It is important to be social media savvy also. Lots and lots of things that people think are coming down the pike in the next 10 or 15 years. This is going to be how we are going to be approaching medicine. What that's going to bring to the table is big data, experimental data, clinical data, biological data, and the exploding world of variables. This is here. We need to corral it. We need to study it better. We need to be good stewards of this. We cannot let the machines rule us. We have to figure out a way how we are going to deal with these machines. At the heart of this is a paradigm shift in how we think about research. Typically, you come up with an idea, you collect the data, analyze, and then figure out if your hypothesis is right. Now we are entering a different era. Hypothesis does not matter as long as you have high quality, multidimensional data, be it imaging, be it ECG, be it variables, whatever. You can feed it into a machine, analyze it, you have data. It's as simple as that, but it's as complicated as that. And I'm going to show you what I mean by that. This is an interesting concept. In the next decade or 15 years, we may not have to experiment on humans before we work on our digital twins. Think about the potential. Why experiment on humans? Why do we want to do a placebo-controlled drug trial on a human when you can potentially work on something on their digital twin? This is coming. This is here. You're going to be hearing more about this. At the heart of it all, I am an imager. I'm a cardiologist, but I'm also an imager. In my opinion, the biggest utility of precision medicine and artificial intelligence is going to be in cardiovascular imaging and all these variable electrophysiologics. I use that term very broadly. So, it is important to recognize, it is absolutely important to recognize what needs to be done in order to get high quality results at the end of the whole thing. Garbage in, garbage out. That's what people talk about data. Whatever we're going to put in the machine is what's going to come out of the machine. So you need high quality data, you need a training data set, you need to train the machine to recognize, and then you need to validate. And this is probably the most important part of the future. having reliable, robust data sets. Cannot underscore importance of this. I'm going to use a few examples to prove my point. Aortic stenosis, we've heard a bit about aortic stenosis and how we are physical examination looking for signs and symptoms, then come echo and CT and MRI and this and that. Today, this is here, using artificial intelligence to interpret an entire echo, not just the valve, with inbuilt prediction, ascertaining severity of the disease. This is a fatigue-free process. You can quickly do it, and in the right selected patients, it can provide the right data. You connect it to mortality data, and now you have incremental prognostic value. This is an example. This is not hypothesis. 400,000+ individuals from Australia linked to mortality data. Look at how the data performs if collected appropriately. Receiver operating characteristic curve. So diagnostic accuracy is 0.97. 1 is perfect. This is as good as perfect if done right. And it does provide incremental prognostic value. So this is not future. This is here. This is going to become the norm of the law of the land in the next few years. This is something I'm really proud of. This is collaborative work that we've done. So looking at, Rusha Parikh just talked about calcium scoring and prognostication, etc. This is taking it a step further. This is my work with University of Oxford in UK that we did a few years ago, or it is ongoing work. Looking at non-invasive coronary angiography, CT angio, looking for inflammation in the wall, using artificial intelligence and radiotranscriptomics to detect which person is potentially going to have a future MI. This ended up being a study. Now, the reason I've chosen to talk about this specific thing is because I want to make a very important point. The data has to be robust. So the technology is there. What we did was we tested the data in a German population and then validated the data on the Cleveland Clinic North American population. Why is it important? Because ethnicities, diversity, all those things matter. What we found in this context was that this technology works really well no matter who you test it on. This is going in front of the FDA in the next few months to be approved. You're going to be hearing about this. AI coming down the pike in the next few years. This is example from our work. This is a real example. 56-year female, non-diabetic, cohort equation risk is 2.3%. LAD, CIRC, RCA, they look good. Conventional recommendation is lifestyle modification. You measure it for inflammation. She falls in the 93rd percentile. Her risk is upgraded to slightly higher. This person, recommendation switches from lifestyle to atorvastatin, to statin therapy. Look at the potential power of this. Serial imaging. Can we use this? This is somebody who had a CT angio as a 46-year-old in 2012 because of issues. Okay? Patient was on rosuvastatin. 2016, unchanged. 2021, unchanged. Now, the new technology was applied on the same patient, 7.8% or 7.8 risk, which put the patient at 94th percentile. In 2016, after therapy, 5.5%, 5.5, the score reduced to 83rd percentile. Now remember, patient said, I was having side effects. I want to stop my rosuvastatin. What happens in 2021? The CT angio remains normal. This inflammation parameter has changed. So we are entering a phase where we can look at and pontificate and prognosticate based on AI-driven normal CT. What looks normal CT angio to a human being, this is what the machine is telling us. And there's robust data with outcomes. But it is absolutely important to question big data and recognize bias. This is real stuff from the American police camera system, or Microsoft, IBM, all these things, they came up with AI-driven facial recognition software. Unfortunately, it does very well in white men. It does poorly in dark females. Why is that? Because the data that was used to create the original software was flawed. It had mostly white men. This was the basis of a lot of racial discrimination. This is another example. You want to identify a lion in the wild? You need to identify the lion in all different angles. If you just look at the face, the computer is only going to look at the face. It may not recognize the lion if it is sitting next to you. Creation of the bionic human. Creation of the bionic human, electrophysiology, there is a variable. I think you can walk, you can look like Ranveer Singh, you know, he likes to dress up like whatever, that movie star. You may look like a bionic man with all these variables. They're going to change the world, no question about it. They're going to change the world. But as we successfully navigate this space, what are the things we need to look at? Battery life. Is it comfortable? Is it reliable? What is going to be the computing power that is needed? Is it going to be accurate? Is it going to be safe? Privacy, data privacy. Is it going to be easily hackable? And what the heck are we going to do with this? The ethics of all this. So we still have a lot of questions to ask. Two things I'm going to point out. This is a famous study, Apple Heart Study, 420,000 participants. It works great to detect arrhythmias, but there's a 0.5% irregular pulse notification in normal population. Do the math. If the entire world's population starts walking around with an Apple Watch, and if 0.5% of them have false alarms, that's millions of patients. We did this study in what we thought was a relevant patient population post-op, because the rate of AFib is high in these post-op patients. What we found was the sensitivity was only 41%. This is a Cleveland Clinic study. 31% had inconclusive results. So again, careful what data set we are using. General applicability. This is one of my favorite papers to highlight the point. This Mayo Clinic data that says prospective evaluation of smartwatch enabled detection of LV dysfunction. It works great, but look at table 1, 94% white patients. How many of you here are white? I'm not. So we need relevant data sets. We cannot extrapolate based on single gender or single race. Moving on to where I think other things are happening in this arena is the refined and abbreviated drug discovery programs. I think we are going to see drugs approved much faster, driven by genetic studies. Genetic studies can identify candidate protein to target, to develop therapy for. Then you can utilize bioinformatics to target drug assessment. Animal studies. Then you can go screen humans for genetic testing. If they are genetically predisposed, you can test the drug and do phase 1, 2, 3 trials. The time it will take is going to be less than a decade. You heard about this mavacamten. This is one of the precision drugs that was developed for hypertrophic cardiomyopathy. I was fortunate enough to lead the trial. that got, one of the trials that got this approved. This is a precision drug treated at 32 weeks, 90% of patients do not need surgery or alcohol septal ablation. This was one of the top 5 FDA approval announcements just last week. Gene therapy is emerging. We are taking adenovirus, removing its base DNA, injecting the required DNA to generate protein that is missing in action, and one injection can potentially cure the disease. This is Tenaya is a pharmaceutical company I'm working with. I'm helping lead their program of gene therapy in gene-positive hypertrophic cardiomyopathy patients. So watch out for this space in the next 5 years. CRISPR editing. Gene editing is happening where you are curing at an embryonic stage. This is not science fiction. This is happening. Once we fix the ethical issues associated with this, watch out. Another important field is cardiovascular disease primary prevention, risk stratification. No longer is monogenic risk, familial hypercholesterolemia is enough. People are recognizing polygenic risk scores. And its potential, this field is just starting to explode from birth risk prediction to prognosis, the full spectrum. And look at the prognostic value. You add polygenic risk score to clinical risk, the C statistic goes through the roof. Its ability to incrementally diagnose goes through the roof. Look out for this space. This is going to change how we practice. Population and digital health, virtual reality. Now, I'm also an operations guy, clinical operations. So you have to think about the bigger picture, how to impact the greater population. Can we use virtual reality to help deliver care in far-flung cases? COVID has already taught us the value of telehealth. Can we push this envelope further? This is already happening as a pilot project in Western Australia. This is something that I'm helping develop a program with a startup company. A complicated but simple, basic heart failure metrics that we will be monitoring on every patient to help predict who will be readmitted in 30 days. Readmission costs the American healthcare system $15 to $20 billion. So this is probably a bigger deal than developing new drugs. Can we identify patients who are critical that may code 3 to 4 hours from now and act on them to reduce their risk of having cardiac arrest? Yes, this is happening. This pilot study is happening in Louisiana. This is a cloud picture. This is our map of Northeast Ohio, where we are using private cloud to deliver precise care in acute aortic emergencies, where we do not wait for the patient to arrive before we take them to imaging. The imaging is done locally. We already know through cloud transfer what's happening, and the surgeon is waiting for them. This is here, and this is going to be refined further. So, are these threats or opportunity? This is one of my favorite terms that I learned in MBA school. This is an American military term, OODA loop. Observe, orient, decide, act. All of us we have to do this to grow our business. Clinical research, you promote the research, you get some fame, but at the end of the day, it is about scaling what you learned. It is not the most intelligent who's going to survive. It is the one who's going to be able to adapt the most that will survive the best. At least that's according to Charles Darwin. Growth mindset. requires research, education, innovation. I am a proud believer that the starting point of anything I do is high quality clinical work that gives me all the research ideas to innovate, publish, market, educate, build your reputation, build your brand loyalty, and then the circle of life continues. Somewhere along the line, you get lucky with philanthropy, grants, venture capital, because you do need money to innovate, but cannot underscore the importance of high quality clinical work. But as I've alluded to, the biggest enemy of artificial intelligence machines can be naturally dumb humans. And we have to be careful every step of the way to not let that be the case. Have you seen or heard of the story of the world's longest cow? That's what a machine identified as the world's longest cow. Garbage in, garbage out. In precision medicine, training and validation data set need to be representative of everything, not just gender and ethnicity. Having said that, we do have a very bright future in cardiovascular medicine. So I will leave with the following. You need to dream big, you have to have a desire to evolve, and you have to drive the change. Change and evolution are simply that easy, but just as difficult. On behalf of my family, I sincerely thank you guys for this honor, and thank you again.